Yes, we are live now.
Yeah.
Good evening, respected dignitaries and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcome you all for today's webinar on gastrointestinal disorders in pregnancy, organized by Safe Motherhood Committee of Oxy. So it's my pleasure to welcome the MOC of today's webinar, Dr. Deepti Jammi ma'am. Ma'am is the director and fetal medicine consultant in Jammi Health and adjunct faculty in Savita Medical College. And ma'am has received numerous gold medals for best paper presentation at Oxycon and award for best poster and paper presentation at IAS at Delhi and many other awards. I welcome you, ma'am, and I hand over the session for further proceedings.
Thank you so much, Sahiti. It's wonderful to be a part of Safe Motherhood Committee. On the behalf of our entire Oxy team, I would extend my warm welcome and greetings to the most famous gynecologist from the other states, Dr. Asha Bakshi ma'am and Dr. Kasturi ma'am. Welcome you, ma'am. It's a pleasure as a part of our Safe Motherhood Committee from Oxy. It's wonderful to have both of you here amidst your busy schedule. Thank you so much for joining us, ma'am. We will start now with Tamil Thai Varthu, followed by the lamp lighting.
திசையும் புகழ் வணங்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திரும்பியந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
The lamp lighting. Thank you so much, Sahiti. Now, after invoking the blessings and to start this, officially to start the CME, on behalf of the entire Oxy team, led by the dynamic leadership of Dr. Jairani Kamraj and ably assisted by Dr. Kundavi ma'am, I would like to invite Dr. Rajshri ma'am, who's the senior sonologist, obstetrician and gynecologist, who's a part and the head of Safe Mother Committee team. I would invite you and who also is the most senior most person who guides all the juniors for us in organizing the Safe Committee members committee meetings, and we have been doing this regularly on every third Thursdays of every month. And today it's an interesting program dedicated completely to gastrointestinal disorders during pregnancy. I would like to welcome Dr. Rajshri ma'am. She is a senior consultant at Shri Swasthya Clinic Center for Women and Children in T Nagar, Chennai. She holds the executive committee member at Oxy, chairperson at Oxy Safe Motherhood Committee, a special interest for vaginal deliveries, basically in high-risk pregnancies, mothers, and she's been a contributor to one of the chapters in Management of Labor, 3rd edition, textbook for PGs and practitioners. I welcome you, ma'am, to welcome the audience.
Thank you, Deepti, for the very kind words of introduction. And it gives me immense pleasure to welcome all of you all for this distinct webinar, which is focused on gastrointestinal disorders in pregnancy, Thank you, Asha Madam, for accepting our invitation immediately and being here for a webinar. It's an honor and privilege. Thank you, Madam Kasturi Madam, for accepting our invitation and for being here to say a few words. I also welcome all the Dr. Nitya, who is going to give a talk on nausea and vomiting. Dr. Bharat for readily accepting our invitation and to give a talk on constipation as well as part of the panel. Dr. Dhanlakshmi Madam and Dr. Shanti Vijayaraghavan, who will be doing the dialogue on pruritus in pregnancy. Dr. Rekha Kurian Madam, who will be moderating the panel. Dr. Shanti Ma'am, Dr. Shobna Mahadevan, Dr. Madhumita, and Dr. Bharat, who will be the part of the panel. I welcome all the delegates and all the seniors who have logged in for this webinar. Pregnancy, we know, is a transformative journey, not only for the expectant mother, but also for us obstetricians. Gastrointestinal disorders during pregnancy pose unique challenges that demand our attention and expertise. From the common discomforts like nausea and heartburn to the more complex conditions like jaundice in pregnancy, understanding the intricacies of these disorders is crucial to ensuring the well-being of both mother and child. Over the course of this webinar, we will delve into the latest research, clinical insight, and best practices in managing gastrointestinal issues during pregnancy. I hope this collaborative effort will enhance our understanding of this problem. With these few words, I now request our chief guest to address ma'am, Asha Bakshi ma'am, to address and say a few words before we start. Can we
have a CV for Dr. Asha ma'am, please? Asha ma'am requires no introduction. Thank you so much, Asha ma'am, for joining us today. It's a pleasure to have you as a chief guest today. And she's a lead consultant at Dr. Asha Bakshi Center, Motherhood Hospital, Indore. She is the vice president of VetZone Foxy, treasurer at ISAR, holds multiple positions, multiple levels. She's been a chairperson at Foxy Infertility Committee, whatnot. She's been a past president of IOGS. So to her credit, she's been a recipient of Dr. Kumud Tamaskar Award at Foxy 2008-2009 and had organized multiple endoscopy conferences, and she's a part of ISAR and Joint Secretary Committee of FFS 2016. Ma'am, it's a wonderful meeting to have you to be present as a chief guest for us. And please, can we have a few words from you for this in this occasion?
Thank you very much, Dr. Dipti, for such a kind introduction. And first of all, I must admire Dr. Rajeshri. Her voice is so sweet, so convincing. The way she spoke to me, I thought, oh my God, she speaks so well. And now coming to Jaya, the president of Foxy. I know her from long time, and she was the first one to invite me to Chennai when I was infertility committee chairperson. And that's the time I came to know her even much more. And she's very active, and I've always seen her full of energy and wants to be associated with all the activities that are allocated to her for Foxy. So I'm sure that if she's, first of all, I wish all the best, and I'm sure if she gets elected, she'll be an asset to Foxy. Then today's overall the program has been really very well selected, and I'm so happy to be the co-chief coach to be on the same platform as Dr. Kasturi. Hi, Dr. Kasturi, how are you? And today, all the topics that have been selected are very good. Nausea, vomiting, pruritus in pregnancy, and hepatitis, and so nice that you have even involved the gastroenterologist, which is very good. And these are small things. Constipation, people think what's there, what to talk, but there are so many things, and many times the biggest problem a patient has in her pregnancy is constipation, and that's the time I've seen patients not wanting to conceive in the second time. Nausea, vomiting, sometimes it gets so worse that you have to terminate the pregnancy. And I remember, now I don't do surrogacy, but those days when I used to do surrogacy, one surrogate I had to just terminate because we were not able to control her nausea, vomiting at all. So it can be really very serious condition. And jaundice, we all know, we all have lost the patients for jaundice during pregnancy. Pruritus gestational is not to be taken easy at all. Sometimes we have seen sudden intrauterine fetal death associated with cholestasis. So I think topics selected are very good and they are important for us in day-to-day practice. I think that's how we can be really empathetic to patient. It's not just dealing with abruption, placenta previa, doing cesarean. It is overall management of the patient. And this is what we want is our patient should be happy and should have good memories of happy. And if all these small problems are solved in time, then I'm sure the pregnancy has very good impact. So thank you very much once again for inviting me and all the best and wishing you a very happy learning through this webinar. Thanks.
Thank you, ma'am. Thank you so much.
Thank you so much, ma'am. Very true. I think emotional connect with the patient, understanding what they go through is extremely important. For us, it's just nausea, vomiting, and constipation, but then for them, it's completely different altogether.
Sure.
Very well said, ma'am. At this point of time, I would like to invite our guest of honor, Dr. Kasturi, ma'am. Thank you so much for joining us. It's a pleasure again to have you with us. She was the immediate past president of KSUOGA, and she was the president in 2022. She's a professor and head of the Department of Obstetrics at KIMS Hubli. She's held excellent, severe, high-grade positions everywhere, principal investigator in research projects. She's been an ex-president in HDOGS, ex-secretary general, MCI inspector, UG/PG examiner. I'm sure, ma'am, we have lots to learn from you. And she's been a faculty at several state, national, and international conferences, conducted many workshops for both the KSUOG people and all over India. Thank you so much, Kasturi ma'am, for joining us. Can we have a few words from you on this topic and regarding Oxy 2?
First of all, thank you, Dr. Dipti, for such a nice introduction. Very beautiful words. Very pleasant evening to one and all. Ellargu namaskara. And first of all, I am very, very happy to chair this session as a guest of honor along with Dr. Asha Bakshi. I know Madam since many years. And it's such a pleasant moment that with her. And I totally agree with whatever she told. You know, every word what she told was very practical and very listening. So thank you, Madam, for being with you on this platform. And I immensely thank Dr. Jairami. She's my good friend and we were together in many conferences. And we wish her all the best for the Foxy elections. I'm sure if she'll get elected and she'll make a huge impact in Foxy. Thank you, Jairami. And also I thank Dr. Rajeshri and Dr. Kundan for this and very nice, beautiful words. Even I like the voice of Dr. Rajeshri, madam. Very beautifully you introduced and very, very beautiful. It makes so homely. Your words make us feel like very homely.
Thank you so much. We are blessed.
I thank all the Oxy Safe Motherhood Committee, all the best for this program and very beautifully chosen topics like vomiting in pregnancy, simple, constipation, pruritus. For us, we feel simple, but it makes a huge impact on the patient. When a patient is suffering from pruritus or hyperemesis, it is really makes their day-to-day life so very problematic. I've even seen doctors suffering so much from hyperemesis. We had to terminate a gynecologist for pregnancy twice because of her uncontrolled hyperemesis, the way she was suffering. So if we see such cases, we feel it's so very important to address these topics. Even simple topic constipation, we feel this thing. But it is so very important to address that because patient suffers a lot. Even pruritus is such an excellent topic because pruritus is not just skin condition. So many times it may turn out to be intrahepatic cholestasis. And then because they complain of pruritus, this redness in palm and soles, then we think of intrahepatic, then we do the investigations and we found out, and then we can be really very, monitor them very cautiously, these patients. And one more, hepatic disorders, yes. It's on a rise. I'll tell you, in the past, we hardly used to see any hepatic disorders, very rare case, but now it is not so. If you see our obstetric ICU, we have at least 2 or 3 cases with all this raised bilirubin, variety of hepatic disorders. So many we are seeing, And often we need to call a gastroenterologist for this. So thank you for including a gastroenterologist for this topic. So our knowledge will be updated, and we can transfer the same knowledge to our day-to-day practice, and then really make a difference in the lives of people. Because in the past it was a very high mortality, but with the now I think the mortality is quite less compared in the past, and we are able to manage all these hepatobiliary disorders in a good way. So thank you for inviting me for this excellent webinar and this academic extravaganza, which is going to really make a difference in the patient's life whom we are treating by the knowledge we gain from here. So I once again wish all the best for this program, and thank you for inviting me. Thank you once again.
Thank you so much, ma'am. Thank you so much, Kasturi, ma'am. Thank you for your good, nice words. Now we will head on to, I hope both of you will stay with us for some time.
Yes,
now
sure.
we are heading on to our welcome. We are going to put to our welcome Oxy prayer by Rashri.
Thank you, God. In humility we gather. In gratitude we pay for all the good things you've given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and magnanimity of your endless love. Thank you.
Thank you, ma'am.
Over to you, Deepti. We can start these.
Thank you, ma'am. Now, let's start the program. As everyone said, that we have interesting topics lined up, and now I have a young, dynamic obstetrician, Nitya, who is a very close friend of mine, giving her first talk in nausea, vomiting in pregnancy. And she is a consultant obstetrician and gynecologist at Madras Medical Mission, Chennai, and she's a part of the Safe Motherhood Committee at Oxy. She holds special interest in high-risk obstetrics and reproductive medicine. Over to you, Nitya. The next 15 minutes is all yours. Nausea, vomiting, we see day in and day out. So let's see how you unravel the mystery for us. Over to you, Nitya.
Thank you, ma'am, for those kind words. Yeah. Yeah. The screen is visible?
Yeah,
Yeah.
go ahead.
Yeah. So the first topic would be on nausea and vomiting of pregnancy. Coming first to the definitions of nausea and vomiting of pregnancy and the hyperemesis. So nausea and vomiting, usually the onset is in the first trimester, and make sure that we have excluded the other causes. The prevalence rates are around 50 to 80%. And the retching is there in about 50% of these patients. And this is more common in the Western countries. Whereas hyperemesis gravidarum, there is a protracted nausea vomiting with a triad of symptoms like 5% of pre-pregnancy weight loss, dehydration, and electrolyte imbalance. And this occurs in only 2% of the pregnancies. Now, this has been more common in the women from India, Pakistan, Asia, and New Zealand compared to the Europe and Americans. What are the risk factors? Now, the risk factors would be younger nulliparous, under or overweight women, multiple pregnancies, molar, GI disorders, previous history of H. pylori infections, previous history of hyperemesis in previous pregnancies, family history of hyperemesis, or a history of motion sickness, and female fetus. Now, what is the pathophysiology of nausea and vomiting? It is a multifactorial. So the hormone stimulation, like the HCG, high levels of HCG in twins and GTT could be a cause. High estrogen level will cause a decrease in the GI motility and the gastric emptying. And progesterone levels are high, which causes relaxation of the gastric sphincters and the impaired gastric motility. And thyroid hormones, we see that there's a physiological gestational transient thyroxitosis, that is raised FT3 and low TSH found in about 66% of hyperemesis patients. Dietary deficiency, psychogenic, genetic, allergic, liver dysfunction, and vestibular system dysfunction. So this is a diagram showing the multifactorial effects. How do we know the severity of MVP? Now we have the scoring system, which is very simple. All that we'll have to do is just give it to the patient and ask them to mark it. So this says that if the scoring is less than 6, it is mild, moderate is 7 to 12. And when it is scored more than 13, it means that the patient has severe symptoms. Now, what is the importance of history taking and examination? Other than the routine history taking points, now we are going to quantify the severity using the score, and we can also exclude the other causes. And on examination, other than the vitals that we are checking, it is important to check the weight, the signs of dehydration, and the signs of muscle wasting. Now, coming to the investigations, the first investigation that we usually do is check for the ketones. So by doing a simple dipstick, we will know if there are ketones. And by doing a midstream urine, now this can tell us if there's any infections and dehydration. By doing electrolytes, we will know if the patient is having a hypochloremic metabolic alkalosis or an acidosis. By doing just a full blood count, we will know if the cause could be because of leukocytosis, infection, or an inflammatory cause. And by checking just blood glucose, we will know if the patient is diabetic, because in that case, it could be because of the decreased antral contractility and precipitating gastric dysarrhythmias. And by doing an ultrasound, we will know if the patient is having a intrauterine pregnancy, multiple, or a molar pregnancy. And also we will know if there are any other causes like a calicula in the gallbladder or in the renal. And by checking the thyroids, both of the extremes can cause nausea and vomiting. And in liver function test, mild raised bilirubin or a raised SGOT, SGPT can be seen in up to 4% of patients. And by checking amylase, raised amylase will also be present because of the excessive salivary production of amylase. Now, these are the differential diagnosis of nausea and vomiting of pregnancy. Now, we have gastrointestinal conditions, genitourinary tract conditions, neurological conditions, metabolic conditions, and miscellaneous one. However, pregnancy-related conditions like acute fatty liver of pregnancy and preeclampsia should always be kept in mind. What are the maternal and the fetal effects? Now we have various maternal effects ranging from simple nutrition, weight loss, muscle weakness, to having Wernicke's encephalopathy or a hemorrhage, splenic avulsion, esophageal rupture, or an ATN, and also depression and anxiety is quite common. And neonatal effects, we've seen that the papers have showed that there is a lower rates of miscarriage, probably due to the robust placental synthesis in healthy pregnancy, higher low birth weight, and small for gestation and premature infants. Now, what do we do about the prevention and treatment? Now, this paper in 2012, now this shows to determine, this paper was done to see, to determine whether the initiation of treatment, that is preemptive treatment, which means where we start the treatment even before the symptoms occur. Now, this is an RCT done. Now, this says preemptive treatment with antibiotics is superior to the treatment that starts only when the symptoms have already occurred, in decreasing the risk of severe forms of MVP. Now, after a simple assessment that has been done with the investigations, now we can make the scoring. And if it is less than 12, earlier in the previous slides, we have seen that if it is more than 13, it means it is severe. Now, if it is less than 12, then if there are no complications, all that we'll have to do is just give a lifestyle modification, dietary changes with some oral antiemetics. And if the scoring is more than 13 and if there are no complications, then an ambulatory daycare management can be done until there is no ketonuria. That is, by giving an IV hydration with a normal saline and potassium if there are no contraindications, and antiemetics can be given. If there are complications and the score is more than 13, then an inpatient management would be required. To be kept in mind are the thromboprophylaxis and the multidisciplinary team approach. What are the non-pharmacological therapies? Now, dietary modification, as we all know, we advise the patient to take more of proteins, taking in more liquids, small volumes of salty liquids, frequent small meals, avoid spicy and fatty foods, eliminate iron, crackers can be taken, and avoid the sensory stimuli. This paper was in 1992. Now, this says a periconceptional multivitamin mineral supplementation, which can be started 1 month prior to fertilization, can help to reduce vomiting, nausea, and vertigo in pregnancy. Now, this is another non-pharmacological therapies would be emotional support by the friends and family, supportive psychotherapy, hypnotherapy, and behavioral therapy, which can also help the patient. The next comes the ginger. Now, ginger improves the GI motility, improves the flow of saliva, bile, and gastric secretions. And it was found that it has a similar activity to the ondansetron, and the extracts from ginger will inhibit the growth of H. pylori strains. Now, this paper was done on ginger. It is a double-blinded randomized controlled trial with the powdered root of ginger. Now, this says that a daily dose of 1 gram during 4 days was much better than the placebo in diminishing and eliminating the symptoms of hyperemesis. Now, coming to the acupuncture, now this is a P6 Nguyen point, which is 3-finger breadth above the crease, will decrease the nausea in patients with chemotherapy-induced nausea and post-operative. And hence, this principle was also used in pregnancy patients. Now, application of pressure can be done either manually, or an elastic band is also available. Now, these days, we also have a battery-operated relief band. Now, these are worn on the wrist, and the FDA has approved it. This RCT shows that by doing acupuncture, there is a possible to reduce the NVP significantly with acupuncture. Now, coming to the pharmacological therapy, now the first comes is the pyridoxine and the doxylamine, which are category B drugs, and these are safe and effective. Now, in 2016, an extended release of this combination was approved by the FDA. Now, adverse effects would be sleepiness, tiredness, drowsiness, which occur in 28% of patients, and fetal safety has been mentioned in numerous studies. Now, this study shows doxylamine succinate and the pyridoxine hydrochloride delayed release was safe and well tolerated by the pregnant patients when up to 4 tablets daily was used. Next comes the metoclopramide, which is the category B drug. Now, this will increase the lower esophageal sphincters and increase the gastric transit. It will stimulate the antral contractions. Metoclopramide is use is limited by its side effect profile, which includes dystonia, restlessness, and somnolence. In 2009, FDA added a black box warning due to the risks of tardive dyskinesia with chronic use. And now this is again a randomized control trial, which compared it with the other promethazine, which says that the therapeutic effects were same, although the adverse effects were much lesser in metoclopramide. Now, coming to the phenothiazines, now these medications are central and peripheral dopamine antagonists, promethazine, prochlorperazine, chlorpromazine. Now, these can be given orally, rectally, IM, or IV. Now, there is a significant excess of malformation in infants when women had taken phenothiazines during the first 3 months of pregnancy. Now, coming to the antihistaminics, which are category B drugs, and the side effects just included sedation, dry mouth, lightheadedness, and constipation. Women suffering from morning sickness, which was not controlled by non-pharmacological methods, can use antihistaminics safely. Now, coming to the next set of drugs, now here the evidence is limited, but the use has been increasing. The adverse effects would be headache, drowsiness, fatigue, constipation, and prolonged QT interval. So FDA recommends ondansetron not to be given IV more than 16 mg. ECG and electrolyte monitoring will be important for patients with risk factors like arrhythmias, heart problems, and electrolyte imbalance. However, the patient should be explained about its use, and using before 10 weeks should be individualized. Do steroids have a role? Yes, but with caution. So better to be avoided in the first 10 weeks. Now, patients who do not respond within the first 3 days of IV steroids are unlikely to respond, and the treatment should be stopped. For those who do respond, the dose may be tapered over a period of 2 weeks. Efficacious in refractory cases. Now, if recurrent, we can use it for 6 weeks. Now, this is ACOG committee opinion on nausea and vomiting of pregnancy in 2018. Now, this says the first-line therapy would always be convert the prenatal vitamins which contain iron to just a simple folic acid supplements. Ginger capsules can be taken up to 4 times daily. Consider P6 acupuncture. Coming to the pharmacological drugs, the combination of vitamin B6 and doxylamine can be taken. Now, 2 tablets taking at bedtime would help the patients with morning sickness. Up to 4 tablets can be taken. And when taken in a combination of 20 mg, only 2 tablets to be taken daily. If it still persists, then we can go to the antihistaminics, which can be used. And in spite of that, if the patient continues to have symptoms, look for dehydration. If there is no dehydration, metoclopramide and ondansetron or promethazine can be advised. If there is dehydration, then first IV fluids have to be replaced, and metoclopramide, ondansetron, or promethazine can be added. As a last resort, methylprednisolone 16 mg every 8 hourly orally or IV for 3 days, and then taper it over 2 weeks. Now, this is the GTG guideline from 2016, which again says these are the first line, second line, and the third line drugs. This is a systematic review for treatment of nausea and vomiting. Now, this says with mild symptoms, either give ginger, pyridoxine, antihistaminics, and metoclopramide. With moderate symptoms, pyridoxine, doxylamine combination, promethazine, or a metoclopramide would be better. Steroids are beneficial in very severe cases. However, the overall, it was a low quality evidence. Now, when do we admit the patient? In any one of these conditions, when patients are unable to keep down any oral antiemetics, when they continue to have ketonuria or a weight loss, and if there is any other comorbidities, and IV therapy, the multivitamins should always be added. A ringolactate or a normal saline can be given. Thiamine should be administered before dextrose infusion to prevent Wernicke's encephalopathy. When can total parenteral nutrition be given? It is a potentially life-threatening intervention because there are many complications like infection, cellulitis, line failure, pain, thromboembolism, and bacteremia. And the complication rate is quite high, which is 18.5%. And this has to be used as a last resort. Okay, so as a summary, the level A evidences, it says a vitamin B6 or with a combination with doxylamine is quite effective. Prenatal vitamins for 1 month prior to fertilization will reduce the severity, and level B evidences show that ginger can be used as beneficial effects, and methylprednisolone can be used in only refractory cases. Level T evidence says early treatment of nausea and vomiting may be beneficial. IV fluids with the intravenous hydration should be used for patients who cannot tolerate even oral liquids, and correction of ketosis and vitamin deficiency should be considered. Enteral tube feeding, that is nasogastric or nasoduodenal, should be initiated as a first-line treatment to provide nutrition, and peripherally inserted catheters should be utilized only as a last resort. These are my references. Thank you.
Thank you so much, Dr. Nitya. It was a wonderful presentation, and you actually brought out all the points, literally all the points, starting from pharmacological treatment to even psychological therapy, behavioral therapy, including the family members. I think each and everything is important. You also spoke about alternative therapy. That's extremely important, and the scoring system. I think you brought out literally everything in nausea, vomiting. I know it's not easy to treat a patient when she comes with hyperemesis, but you did a wonderful job. Thank you so much, Nitya.
Thank you. Thank you, ma'am. Thank you.
Well done, Nitya.
Thank you, ma'am.
Can we go on to the next presentation, ma'am? It's my pleasure to have Dr. Bharat, one of the senior gastroenterologists from Apollo Hospitals, Chennai. Thank you so much, sir, for joining us. It's a pleasure to have you with us today because the entire 2-hour session is based on gastroenterology, and none other than a gastroenterologist could give us answers during pregnancy. So he's completed his undergraduation from KMC and post-graduation of internal medicine from MMC, Chennai. Most prestigious colleges, both in Chennai, and he was working at UK, Lancashire, and National Health Sciences for almost 4 years. He's a member of RC, Royal College of Physicians, and he's super specialized in medical gastroenterology, and he's been a part of Apollo Group. And his special interests include training and also a very active member and participation in many conferences so far. Thank you so much, sir, for joining us. We are waiting to hear you talk on constipation in pregnancy.
Good evening, and thank you very much for those kind words. I'm not able to share the slides because it's still, the other person is still sharing. Thanks, Oxy, and thanks, Rajshri Madam, for asking me to give a small lecture. I've kept it very simple after Dr. Nitya has given such an extensive talk on nausea and vomiting. I never thought it's going to be so extensive, but I've kept it as simple as possible. It's going to be very, very straightforward and very, very simple. And let me try and, okay.
Sahiti?
I think you can, she stops sharing, sir.
I think
can you try sharing this?
1 second, just give me a minute.
Nitya, you've stopped sharing? Yeah, yes.
Yeah.
Okay. So I've been asked to talk on constipation in pregnancy, which, as rightly mentioned, constipation can be a very, very distressing symptom, whether they are pregnant or non-pregnant, because amidst Indians, it's a very, very, very common symptom. And especially amidst South Indians, if they don't empty their bowels at least once a day, they are not at all normal. They feel something is happening to their head, or they feel they're not all that well. So, giving a brief introduction about constipation in pregnancy, it's the second most common GI complaint in pregnancy after nausea and vomiting, and it can affect to the range of 25 to 40% of pregnancies, and symptoms usually present more prevalently in the first and the second trimester. And subsequent pregnancies can have a higher risk of constipation for reasons unknown. And the risk factors being sedentary lifestyle, and people are getting pampered. They are not allowed to do good exercise, or at least a decent exercise. They have a very sedentary lifestyle. They take a lot of bed rest, and the fiber intake becomes less, and they can have an inadequate fluid intake. And certain medications which are basically given for anemia correction, like iron and certain mineral supplements, can all cause or worsen the constipation, which can normally happen during pregnancy. Going on to a brief introduction about our colon. Our colon is roughly 2 meters long. And as we all know, the inner lining of the colon is not sensitive to touch. It is sensitive only to stretch. When we have an adequate bulky motion, when it stretches the wall of the colon, the colon starts moving. The motion is moved from the right side of the colon to the left side. The distal most 15 centimeters of the left side of the colon is sensitive to touch. When motion comes and touches the distal most sensitive portion of the colon, you have a reflex to pass through. And our colon is designed in such a way that if you go and squat, like how we squat in an Indian closet, It straightens up, the sigmoid colon straightens up and the sphincter relaxes. And when you relax the external anal sphincter, which is under the voluntary control, you tend to empty your bowels quite well. And constipation generally happens if we have two of these problems. One, if for some reason the motion is moving very slow, or the transit of the colon, or colon transit time is prolonged, then more and more water gets reabsorbed and motion becomes harder and patient finds it very difficult to evacuate. Or if they have a problem in the process of defecation, which is a coordinated process where the sigmoid straightens up, the internal anal sphincter relaxes, and the external anal sphincter relaxes, thereby it just expels the motion out. You can have constipation if you have problems in any one of these two. If you have a slow transit, you tend to get bunged up, or if you have a problem in the process of evacuation per se, and also you'll have difficulty in clearing your bowels. So with this in mind, let's address the problem during pregnancy. So in most of the cases of pregnancy, it is predominantly a functional problem, which means the transit of the colon gets slowed down. We don't expect that much of a structural problem. The slowing down of colon movement can happen due to various reasons. I'll come to those as we go on. And we have to definitely rule out two other problems, which might not be the common reason, but which are very significant problems, which definitely needs to be ruled out in anyone who's presenting with constipation. Whether there is some sort of a mechanical problem which is preventing the evacuation of the colon, or is there any other systemic diseases like diabetes or significant thyroid disease or any other major illness, which is in fact retrospectively slowing down the movement of the colon, and thereby the person is going for a significant constipation. So as we all know, functional problem is the most common reason for constipation in pregnancy, and the risks being a sedentary lifestyle, not doing even a light physical activity, not drinking adequate water, not taking adequate fiber, and medications in the form of certain iron supplements and calcium and vitamin tablets can all precipitate a person for recurrent constipation. And constipation can be a very annoying symptom, especially during pregnancy. People don't find it very good at all, and they find it very heavy, and they find it very, very bloated and clogged up. So unless and otherwise they get relief quite well, it is not. And with the principle of colon transit and the process of evacuation in mind, we can address this problem in a very, very simple way to begin with, and then we can add on certain medications if they don't respond to the basic treatment strategies which we advise. And don't forget to rule out any other mechanical or other systemic problems as we go on. And we should always have a tag over the certain alarm features, which includes blood in stools, or which includes progressive weight loss, or any strong family history of colon malignancies, all certain or late pregnancies wherein a patient has been having significant other associated problems. They all needs to be ruled out. So when we go across to the history or evaluation, there are certain criteria, as she was talking a very with lots of papers in hand. If we take the Rome criteria, which is one of the criteria which we use for constipation, we need to know about the consistency of the stools, frequency of the stools, duration of constipation, more than 3 months. And in those, if they are not a sense of bloated sensation and abdominal pain, all those things have to be in detail evaluated in the history. So first, we'll have to assess how or quantify the constipation per se. How is the motion and how frequently is she passing stools? What is the consistency? Is she having a very hard pellet-like stools, or is it a very simple incomplete evacuation which is causing trouble? All those things needs to be evaluated when it comes to bowel frequency and consistency. And certain alarm features like presence of blood, significant abdominal pain, and bloating can be a very subjective phenomenon, which can be because of lots of problems in a person who's pregnant. Food intolerance and acid reflux and delayed emptying and hypothyroidism, gestational diabetes can all result with abdominal bloat and constipation and pain as well. And certain important history about to identify or to be of concern about pelvic floor dysfunction. One like straining for stools, and if they are used digital evacuation, and if they're using perineal pressure to facilitate defecation, then if those histories are there, we have to seriously contemplate about the pelvic floor dysfunction as well. And not to forget other comorbidities like hypothyroidism and diabetes needs to be evaluated. Any other systemic medications for any connectivity disorders or any other problems if she's on, needs to be listed quite well during a proper history taking. And of course, medications which can worsen constipation like iron, calcium, and vitamin supplements, and certain other medications needs to be checked on. So when it comes to evaluation of a person, like how, as was mentioned earlier, to identify the hydration status in nausea and vomiting, we need to think about other general examination conditions like looking up for anemia, looking up for general examination and systemic examination, to check for systemic diseases, and not to mention about the perirectal examination and perineum evaluation, where examination of a pregnant woman with constipation is not complete if you don't do a rectal examination, to check for the sphincter tone and to check for the expulsive force of the patient to decide on the pelvic floor dysfunction. And the examination of the perineum as well is also very important. So going on to the etiology of constipation, the most common problem or the pathogenesis is dependent upon or being blamed per se if they have to talk about something about pregnancy, and rather than any other person and like a normal person with the constipation, the role of progesterone comes first. So progesterone is an hormone which is, as we all know, is more in during pregnancy and gradually keeps increasing as the patient pregnancy continues. And this progesterone has got some significant effect on the GI system. One, it inhibits the smooth muscle of stomach, and it reduces the or it increases the transit time of the colon, and that can result in a delayed gastric emptying, and it can cause a delayed transit of the colon as well. A delayed transit of the stomach will result in abdominal bloat. An increased colon transit time will cause more and more water reabsorption, and that can result in constipation and worsening of the symptoms. So if you are thinking about a pathology or a pathogenetic etiology during pregnancy, it is the role of progesterone and the effect of progesterone on the GI tract. And next comes the common issue with dietary factors like reduced water intake, lack of fiber, and iron supplements, and recurrent vomiting can precipitate dehydration and can also cause constipation. Water reabsorption, progesterone causes increased secretion of aldosterone. Aldosterone causes more and more water reabsorption, and it increases colonic transit time, thereby worsens the constipation. We have to check for other metabolic parameters like hypothyroidism and hypercalcemia, electrolyte imbalances like hypokalemia, and not to forget about diabetes. And other hormones like progesterone-induced levels of motilin, and which stimulates the gastric emptying, reduced motilin activity, and increased levels of relaxin have all been proposed as mechanism for delayed gastric emptying and increased colon transit time. As we all know, the normal colon transit time is between 40 to 70 hours. So if we don't keep ourselves well hydrated, and if we don't take adequate fiber, and when there is a lot of competition for space inside the with the baby and the uterus going gradually becoming bigger and bigger, the process of evacuation itself will become difficult. And physical activity is important. Strenuous physical activity needs to be avoided, but light physical activity is what is advised. Strenuous physical activity will worsen the constipation as well. And last, as I said, competition for space inside. So mechanical factors like the physical impedance due to the uterine and intestinal movement, fetal compression, pelvic floor muscle dysfunction, and intrinsic colonic diseases also needs to be looked up for, because as they strain more and more, hormonal imbalances called vascular dilatation, and they are more precipitated for developing hemorrhoids as well as they keep straining more and more. And hemorrhoids, if they get secondary infected or thrombosed, can cause trouble, or if the patient strains to pass too much, and if they develop a anal fissure, that will make their life really miserable, and patient will be constantly thinking about the rear end, and their entire life and they'll have a very poor quality of life. So constipation, though sounds simple, is a major problem which can impact the quality of life of a person who's pregnant, and more towards, and starting with an early trimester, it keeps continuing and can be a nagging problem if not tackled with simple interventions at the earliest point. So going on to the treatment, ideal to begin with simple therapy, because everyone is skeptical about medications during pregnancy, especially during first and second trimester. So trying to leave them off medicines to begin with should be the earliest step, and we need to aim for a good dietary intervention, which should aim at a good fiber intake in the form of taking a lot of colorful vegetables. I try to keep the diet very simple in a person who wants to maintain good health or who wants to avoid constipation. The simple rule is anything which is white in color, try to keep less, like your rice, salt, sugar, maida, all those stuff. Your diet needs to become really, really colorful. Lots of nuts and vegetables, preferably cooked, is always better, because if you have a cooked vegetable, the amount of bloat which is caused by the undigested fiber will be a bit lesser. And colorful, and anything which floats on water, you try to eat less. Oily, greasy stuff which might delay the emptying. See, if you take a fatty food, it delays the emptying of your stomach because fat takes longer time to digest. So it intrinsically reduces, or it causes a delayed emptying. Thereby, they tend to feel bloated and might not subsequently eat the right type of fiber. So adequate fluids, every 20 kgs body weight, I advise a liter of water. So you need to think about drinking at least 10 to 12 glasses of water per day. And light physical activity, try to avoid strenuous exercise. Intermittent iron therapy, if you are really concerned about the anemia, try to go on for a biological form and try to keep it in an intermittent phase so that it doesn't constipate too much. And going on to the medical therapy, various drugs have been tried. The safest will be a simple bulk forming laxative, which will be a simple fiber in the form of methyl cellulose or a psyllium husk. And lactulose is also relatively safe, which is an osmotic laxative. What we need to avoid is preferably a stimulant laxative in the form of an irritant like a senna or a mineral oil and castor oil are preferably avoided. And certain other drugs like lubiprostone have been tried, but the safety profile during pregnancy have not been proved quite well. So what I would use initially is to try and put them on a simple fiber. And if they are not tolerating the fiber well, if they feel bloated too much, then we can seriously contemplate lactulose and polyethylene glycol. So keeping it simple in the form of both bulk and osmotic laxative is always the best. Preferably irritant laxatives and stimulant laxatives are avoided in the form of castor oil and mineral oil, which is no longer being used. But we tend to get hooked upon to some stimulants if for a quick result. But if you look at the simple principle, if you have not made the motion really bulky and soft, adding on a stimulant laxative will make things worse. The person will start having more and more symptoms because it will try to move, but the motion will be really bunged up and they will not clear it up quite well. So earlier on, the simple step will be to soften up the stools as much as possible. And if they still not clear the bowels, then you can add on a simple stimulant laxative. I think I have saved the time which was involved in the previous one. Thank you very much. I hope it was useful. I was given 15 minutes. I think I finished within 15 minutes.
Bang on, sir.
Bang on time.
Thank you.
Really a lucid discussion. Deepti.
Yes, ma'am. It was extremely practical and useful.
Very good, sir.
Trust me, it was very useful because we all say pregnancy is a roller coaster ride. And when constipation or nausea, vomiting hits in the first trimester, we really don't understand because they go through a lot. And constipation is a huge thing when they don't feel comfortable at all. And psychologically, they get upset. And the small things like fiber intake or softening the stools even before giving a stimulant, that makes a huge difference. So I think those are the small points that we need to know before. And as you rightly said, not even being an obstetrician, you're telling that the patients are sedentary, they don't work. That's very true. Nowadays, we see a lot of patients not even moving. They sit at home, do a desk job, they come to clinic. Isn't it, Rashmi ma'am? The activity of the patients these days are very less.
Very practical, sir. Very practical.
Very practical.
Day to day, we can use whatever you have told us today. That's really practical.
Very true, sir. Very highlighted. Thank you so much for your presence, sir. Please do stay with us for the panel. We're not going to let you go very soon. So do join us for the panel. Yes, we are coming to one interesting dialogue session. It's always a pleasure to have Dana ma'am and my pleasure to introduce my professor to all of you. Dhanalakshmi ma'am from SRMC is a professor and senior consultant from Department of OBGYN at Ramachandra, executive committee member, very active executive committee member of OXY. Wonderful, excellent teacher in UGPG. Ma'am, welcome. It's an honor to welcome you, Dana ma'am, and followed by Shanti, Dr. Shanti Vijayaraghavan ma'am, as a professor and HOD of Hepatology and Senior Consultant at SRMC and Apollo Hospitals. I'm sure all obstetricians want to hear what to do when we have pruritus, and that too with the gastroenterologist with you. I think it's going to be very enlightening and interesting talk, ma'am. Over to you, Dana ma'am.
Am I audible?
Yes,
Yes,
ma'am.
ma'am.
I think
Welcome,
this is-
ma'am.
My video is not yet on. That is, I'm not able to share my presentation. Dr. Shanti has my presentation. I kindly request.
Shanti ma'am, can you just share your screen?
Shanti ma'am, you have to unmute yourself, ma'am. You're welcome, ma'am. Please unmute yourself, ma'am.
Shanti ma'am, can you please unmute yourself? Shanti ma'am, we can't hear you. Can you please
Shanti
unmute
ma'am?
yourself?
She's talking.
Shanti ma'am, can you hear me? Can you unmute yourself, ma'am?
Yeah.
I have sent a presentation both to Rajeshri and Chitrakala.
Chitrakala.
Shield only, no, today.
Yes, ma'am.
Sahiti ma'am.
Sahiti, can I send it to you?
Yes, ma'am. Yes, ma'am. You can send it to me. I'll share.
I have sent it already.
To Sahiti.
Yes, ma'am. Please send it, ma'am. I'll share.
I have sent Sahiti. I have just sent it to
Yes,
you.
yes. Just now received, ma'am. Give me 1 minute. I'll just download it.
Shanti ma'am is saying she's not able to unmute herself. Yeah, see if you have made her panelist.
Yes, ma'am. Ma'am is in panelist only.
Okay.
Okay, I'll just check.
Yeah, but what about Shanti madam?
Yeah, that is it. It is in PPT mode, right?
Yes, ma'am. It's in full screen, ma'am.
No, is it in PPT mode? What did you send me, ma'am?
It is in PPT mode. Let Shanti madam come in.
Yeah, it's in PPT mode. Sahiti, will you verify? I called her. She said she's not able to unmute. She said she will try again.
Oh, okay, ma'am.
I'll call her again and see. Do you have her number? Wait, let me try. Dana ma'am.
Yeah.
Wants 1 more minute. She says in her phone, she's not able to unmute. She's trying.
Can I keep talking then? Yeah, I am getting the full screen. I can share it.
Shall I share the PPT, ma'am?
I can share it.
Okay, ma'am.
I can share it so that.
So you're sharing the screen, Dana ma'am?
Yeah, I am sharing. Is it allowing me to share?
Sahiti?
Yes, ma'am. All the panelists can share, ma'am.
Okay.
No.
All the panelists have access
is
to
my-
share the
Is
screen.
my screen shared now, right now?
No, not yet, ma'am.
Not yet. Okay. It says screen sharing has failed to start. Please try it again later.
Okay.
I try to. The same thing. So I think you can share and you can move the slide. No problem.
Okay, okay, ma'am.
Not able to share it. Doesn't matter.
Sorry about the delay.
Yeah, Shanti ma'am has come.
Yeah.
So Saditi, what will you do?
Yeah, I
Ma'am?
will be sharing, ma'am.
Okay.
Yeah. You can.
Dana ma'am?
Yeah, we will go ahead. Even though the heading given to our dialogue is pruritus pregnancy, we'll confine ourselves to pruritus related to intrahepatic polycystic of pregnancy, because pruritus, if you if you want to discuss all the causes of pruritus, there will not be an end. So the dialogue is going to be only 15 minutes. We will concentrate ourselves on intrahepatic polycystic of pregnancy, which is commonly seen and which is bothersome both to the patient and to the attending obstetrician, because we'll have to wait for the delivery to happen for the symptoms to completely disappear. Okay, so here we have an expert, Dr. Shanti Vijayaraghavan, who will clear most of the doubts for us. So I made this into a dialogue format. Thanks to so for accepting it. So let us go ahead. So let me present the first case. Can you hear me?
Yes, ma'am. Go on, ma'am.
Yeah.
Yes.
She is a 28-year-old, gravida to abortion 1, cervical encirclage run for obstetric indications. She is DDM and metformin, 30 weeks, and presented with itching all over her body for 3 days, passing normal colored stools and urine, persists fetal movements well till now. And actually, in fact, she had a consultation today with me also. And she has scratch marks on her abdomen, not very prominent, but they are significant. No rashes, not ectric, liver not palpable on what I can say, because the transverse light allowed me to go and palpate the liver. Liver is not palpable. Bile acid was ordered, and she came to me with the bile acid of 22 micromole per liter. And I have referred this case to Madam Shanti Madam for her expert opinion. Is it okay to make a working diagnosis of ICP based on serum bile acid value? Yes.
Okay. First of all, again, apologies to everyone for delaying the presentation. It is generally okay in this scenario to make a working diagnosis of ICP based on whatever values we have been presented with. However, we need to be aware that ICP has no consensus definition from any of the gastroenterology or hepatology societies. It's characterized by pruritus in pregnancy, elevated bile acids, plus or minus elevated transaminases, with a reasonable exclusion of other causes of liver dysfunction and pruritus. So this exclusion is generally we take a clinical history, but you can never be sure. 1/3 of cholestatic disorders can present in pregnancy as an ICP. Now the new reference range of serum bile acids in pregnancy has been recommended as 20 micromoles per liter, according to the latest guidelines from the European Association of Study for Liver Diseases, which is still in print in September 23, Journal of Hepatology. It's been published. So why is the non-fasting serum bile acids being recommended now? Earlier, we used to do fasting bile acids, and also in the non-pregnant state, we do only fasting bile acid, because postprandially, there can be a 2 to 3-fold elevation in the bile acids. However, when you're looking at a pregnant woman, the peak concentration is very important for predicting an adverse outcome. So it's suggested always to do a non-fasting sample in these patients. So when does the risk of an adverse pregnancy outcome like a stillbirth or fetal hypoxia increase at a level of more than 40 micromole per liter? The risk of an adverse outcome increases. And when at any time the bile acids increase to more than 100, the increased risk of stillbirth is established, and it's recommended currently that you need not really repeat the samples any longer as the risk is confirmed. So once at any time of pregnancy, any stage of pregnancy, it's more than 100, you evaluate the patient as, even if the level is going to drop, as a person who has got an increased risk of stillbirth.
So at this stage, would you like to order additional information? Would like to have additional information?
Generally, we would look at the past history, anything suggestive of a hepatobiliary disorder, any chronic liver disease, personal history of gallstones, or earlier history or obstetric history of ICP in either the patient or a family history would be in favor of an ICP, because it's sort of associated. Also, hepatitis C is known to be associated with ICP. A drug history is very important because drug-induced cholestasis can mimic ICP. The most commonly implicated drugs in pregnancy are amoxicillin, and PPI is also implicated, and very importantly, progesterone, which is a commonly used drug in pregnancy. Family history of hepatobiliary disorders is also important.
Okay, so now that you have done a bile acid alone, when to order for additional lab tests? Would you order at the initial visit along with the elevated bile acids, or you wait for some time?
So normally additional tests, we would generally order a routine test like a blood counts, liver function test, and the coagulation profile. So when do we order an additional lab testing would be whenever it is some red flag we have got, some atypical clinical symptom, or there is a very early onset if it's a severe ICP. And we'll have to realize that cholestasis is not one point. It can be the endpoint of a number of disorders, what is coming to light as an ICP. So whenever there is a red flag, sometimes we just have a hunch that this could be something different. We order for more investigations.
Okay. So what test would you order?
Generally, an ultrasound is done to rule out any obstruction most commonly. Apart from that, for all patients, we order a liver function test with a PTINR and blood counts to look at any thrombocytopenia. It could be associated. Always, all the obstetricians anyway ask for a hepatitis B and C. We have got these parameters, and rest would be tailored only according to the clinical situation and the history. Apart from an ultrasound, we don't really order for too many tests. If we have got any obstructive pathology, then we might ask for an MRCP. If we are suspecting any cholestatic liver disease, we may go in for more serology tailored to that.
Okay.
So when you're looking at the next, can you go to the next slide?
Algorithm, yeah.
So this just a simple algorithm. When a person is presenting with pruritus in a clinical scenario suggestive of ICP, we've got three groups commonly. One is in which when you're checking the bile acids, both the bile acids are normal and the ALT and AST are normal. We should continue to have a repeated testing once in 2 weeks if there is pruritus or you have got any concern. In group B, where the bile acids are normal, but there is an elevation of transaminases, then it's probably some other hepatobiliary disorder. The patient has to be worked up. And in group C, where the bile acids are raised and as well as the transaminases are elevated, after a reasonable ruling out of any underlying disorders, then we can consider ICP.
Next slide, please. Now she has got GDM on metformin. Will it add to the risk?
No recent data on any particular risk associated with ICP, because they have not studied in particular. None of the trials have really assessed any of the individual comorbidities have not been really studied. There are no data available. So according to the gastroenterology perspective of it, we don't ask for any specific modification in monitoring the monitoring of LFT or any of the parameters.
Okay. Then next slide,
yes, ma'am.
Can I expect right now she is not icteric? We examined her daylight. She's right now not icteric, but can I expect her to develop jaundice in due course because she's under minimum 8 weeks? Now that she's diabetic, I'm going to terminate a pregnancy by 38 weeks. Can I expect her to develop jaundice later? Should I be prepared for it?
According to world literature, up to 30% can develop jaundice. But in reality, we don't get really a 30% up to 30% developing. It is a much more lower percentage. I don't know, depending on the ethnic groups, this may vary. The cholestasis also may vary. and it's generally very mild. But however, the transaminases may continue to rise throughout pregnancy. But
Okay.
is it important in the prognosis? It's not as important as the bile acids for the prognosis, but it should raise your alert for, is there something else apart from ICP? And there's a composite score which has been now evaluated. However, a combination of transaminases, bilirubin, and bile acids. But in individuality, transaminases and bilirubin have no prognostic value alone.
Okay, having talked of ICP, why would any pregnant mother should develop ICP at all? Because it's so
No.
common, bothersome.
So it is a complex interplay of, as in many conditions with immune pathogenesis. It's in a genetically predisposed individual for someone who has got mutation in the bile acid genes, like the ABC4, ABC11, ATP8B1, which are the most common cholestasis associated gene. These patients are about up to 20% are supposed to have mutations in these genes. Apart from this, in a genetically susceptible individual, as the elevated reproductive hormones, they also act and they can unmask symptoms in a genetically susceptible. The exact environmental factors are not really known because it is very difficult to really associate any clear-cut environmental factor, though this is also supposed to play a role. So how are you, next question, can you move to the next slide, please? The next question is, how are you planning to monitor this pregnancy?
As you are clearly put in your consultation, I would be ordering for LFT weekly and making you consult, take a consultation with you once in 2 weeks. And maybe if LFT is raised rapidly, I'll sit along with you and might consider additional diagnosis. And as a baseline, I'll do a coagulation screen and look out for development of eclampsia pre-eclampsia by a regular urine albumin checkup. And BP measurement, of course, we do it every visit. Maybe this time, so relying on the system, maybe I can take the BP myself, make sure, because she's got a background diabetes too, and she's little on the obese side. So I would do the BP measurement myself.
So the next question for you, ma'am, what are the worries regarding ICP as an obstetrician for you?
The main problem is the sudden IUFT, which just puts us off the track, right? Because whatever be the surveillance, the Jami might have umpteen number of gadgets, but then nothing predicts or prevents a stillbirth in ICP. And they can end up in preterm birth because of expression of increased myometal oxytocin receptors. MSL is more common because of increased colonic mortality, because of the bile acid going to the baby, and increased perinatal mortality. Increased stillbirths could be because of arrhythmia and vasospasm of this placenta vessels themselves can go into vasospasm. So all these factors are not all under my control. So all this will worry. As an obstetrician, I'm a little worried till the patient takes a healthy live baby home.
So apart from the fetal issues, what are the maternal problems you would anticipate?
The main thing that they come to us is they're not able to sleep because they have to be awake to scratch themselves. In fact, I ask them to wear a mitten over their hand so that it doesn't leave intense scratch marks over their abdomen. And somehow these people end up in increased cesarean sections, not directly related to ICP, but somehow they have increased cesarean section. Probably because of so many other factors, we are supposed to, suppose you are planning to terminate a little earlier because of increasing bile acids and transaminases. So the preterm itself will become an indication for a cesarean. And we, of course, any liver disorder patient, we are anticipating an increased risk of PPH in them. And I can expect a liver function to go a little haywire if there is, because of this increased vitamin K reabsorption. So it might upset the coagulation profile, and it might lead to a prolongation of prothrombin time. All these are, again, not under my control. I am not able to do anything. So that is also will add on to my anxiety if I have an ICP patient with me. So now that we have talked, and so I have expressed my concern about the baby and the maternal outcome. So what topical treatment would you offer this patient, because now that she has come with intense pruritus?
Generally, we give a topical emollient just to keep the skin moisturized. And we ask them to have like a bath with not an extremes of cold or hot that can sort of exacerbate and cause more dryness of the skin. And ask them to just apply some soothing gels like aqueous cream with menthol.
Is it available? Can you tell us the brand name for the sake of viewers who are listening to this? Because we prescribe
I
calamine lotion.
normally calamine lotion comes as a regular calamine IP. It comes. I use only that, and I ask them to use a moisturizer without much. It should be it should not be perfumed. I ask them to use Cetaphil, or I just ask them to use plain calamine. Nothing.
And what systemic treatment would you offer this patient? Now she's 22, is her bile acid level.
So the aim of systemic treatment would be, the main aim would be, of course, to prevent the rate of or reduce the rate of adverse pregnancy outcomes, and also to improve the maternal biochemical derangements and to relieve the maternal pruritus. The only drug which fits in currently for all this seems to be UDCA.
And what kind of a drug it is? What is the role it plays in ICP?
Now, UDCA is one of the most commonly, it has been extensively studied, not only in ICP, but in a lot of other cholestatic disorders. So its actions are, it will increase the bile flow, and also it reduces the synthesis of primary bile acids. And also it increases the bicarbonate secretion. So it sort of strengthens the biliary bicarbonate protection umbrella, as it's called. So it's going to protect both the hepatocytes and the cholangiocytes. So it's generally a hepatoprotective effect and increasing the bile flow and reducing the cholestasis.
How is going to favor my baby's outcome, fetal outcome?
So there's a lot of studies on how the fetal outcome is affected. It is earlier some studies had shown a mixed a variant report. Now it is known to protect against a composite outcome that will include stillbirths, preterms, neonatal death, and neonatal admissions, with a number needed to treat of 15. That is, for treating 15 women, one person is going to have a positive outcome. There is also a reduction in preterm births, but this effect is seen only when the maternal bile acids is more than 40. It's not observed in patients where the bile acid is less than 40. It also protects against stillbirth. The mechanism is supposed to be because folic acid is supposed to induce arrhythmia in the babies. This is supposed to be the mechanism behind stillbirths. And if you see fetuses who has been exposed to UDCA versus the fetuses who are not exposed, there is a reduced heart rate variability. So through this mechanism, it might protect against stillbirths.
Okay, thank you. So what about maternal, or how is the mother going to benefit out of this UDCA?
So the fetus is somehow more benefited than the mother. Pruritus, the effect in all the RCTs, it's shown to have a relatively small effect. However, for the mother, even a small effect can be psychologically and clinically very effective. The ALT and bilirubin do reduce in most trials. However, for the bile acids, it does not reduce in all. And so what is a consensus statement currently say is that UDCA, not only for the fetus, but also should be considered for maternal pruritus in ICP, despite having a relatively small effect on symptoms. And again, we have to realize that giving UDCA itself can increase the bile acids. That is, it's a synthetic bile acid, so it's going to replace some of the pathogenic ones. So you might have, for UDCA treated mothers and non-UDCA treated mothers, there could be a difference. However, when you're seeing the cutoff, you have to still maintain that 40 and 100 only. There's no change in that.
Okay. What about the other drugs that are mentioned in the literature, like rifampicin?
So the most commonly read about or discussed drugs are, one is rifampicin, one is cholestyramine, and S-adenosilmethylin. So here for rifampicin, it has been used as a second-line drug. It improves pruritus and bile acids in a subgroup of people who have not responded very well to UDCA. Currently, it's been assessed in RCT, which is called the terrific RCT. It's safe in the third trimester. However, we have to realize that hepatotoxicity can occur in about 5%, but once we are going on monitoring, it can resolve on discontinuing the drug. And cholestyramine does improve the biochemical abnormalities, but the pruritus is reduced to a much lesser extent than UDCA. As to SAMI, it's no longer recommended.
Are we using cholestyramine in pregnancy?
Cholestyramine in pregnancy for ICP. Can we move to the next slide? So what is the final take on cholestyramine in pregnancy in ICP? That is, additional therapies that may improve maternal pruritus can be considered. That is rifampicin, cholestyramine, guargum, which I don't know, it's not available in India, and activated charcoal. But current evidence to support their use is limited. That's a final take as of September 2023. So you might consider it if the patient is not responded, the pruritus is not responding, but it does not do anything to the bile acids as such. But however, can we again move to the next slide? However, this, the previous recommendation is the study of rifampicin cholestyramine in specifically for ICP. But however, there are recommendations by the societies for other cholestatic disorders in pregnancy, that is primary biliary cirrhosis. So what does that say is, in a patient with de novo or worsening pruritus, we can use rifampicin at a dose of 300 to 600 and anion exchange resins like cholestyramine or cholestyramine. We should be separated by about 4 hours. So we can maybe extrapolate to ICP also, though the studies in ICP are lesser than the other cholestatic disorders. So the level of recommendation is B currently even for the other cholestatic disorders.
If you are not getting an adequate cure by the basic UDCA, you can recommend.
You can go for rifampicin. You can.
What about dexamethasone?
So dexamethasone has no significant impact either in normalizing the LFT or in improving the symptoms, and it's not recommended except for the fetal maturity. It's not recommended for ICP.
Okay. And what is the role of vitamin K? Now that we have discussed that we might interfere with vitamin K reabsorption.
So vitamin K deficiency can occur because of the cholestasis itself. Because of the fat malabsorption, you will have all the fat-soluble vitamins are all not going to be absorbed very well. So there's a subgroup with steatorrhea in patients with ICP. So these women will require vitamin K supplements. Also, those who have used anion exchange resins like cholestyramine and rifampicin. Here also, there will be a vitamin K deficiency. So we'll have to consider vitamin K. Especially when we are going to monitor the PTINR, we'll have to give vitamin K.
Okay. Can you collectively talk about drug safety in ICP? We have
So
talked about so many agents.
Yes, ma'am. So we are looking at several parameters in the drug safety, the compatibility in the different trimesters, even the paternal exposure has been studied. Across all the drugs, only UDCA has got all data, and it says a tick mark for across everything, compatibility across all trimesters and compatible in the perinatal and in the postnatal period also, whereas the others have got limited data. How do you, next question, ma'am. So, how do you be planning her delivery now?
Yeah,
Next
with
slide.
ICP in the background, I would wait for 37 weeks. Okay, and if I have to intervene earlier, because if the bile acid is crossing hundreds or 40s to save the mother or the baby, I might end up in a perinatal morbidity from early intervention because of premature ready. And I must also tell her, apart from making her feel for the fetal movements, there is no reliable test from our side to predict stillbirth. We already discussed it in the earlier slides. Inform her that earlier intervention might be needed if lab tests deteriorate. Right now, she could be at 22, but suddenly if it goes up to 45 in the next visit, I might be concerned. So she should be prepared anytime for delivery. I already covered her with steroids. Thinking about this, we already covered up with steroids. Of course, we gave a betamethasone. And okay, now that suppose I have delivered this patient successfully vaginally, assuming, okay, hopefully, how do you expect us to follow this patient postnatally?
So the follow-up of the liver function test depends on the severity, how much it had been impaired prior to pregnancy. So if it's been very much deranged, we'll be following it at very close intervals. Otherwise, the interval is not really specified. And for everyone, it should be normal by about 3 months. This normalizing of LFT actually establishes the diagnosis of ICP. If it's going to be persistently abnormal, then we'll have to rule out any underlying liver disease, mainly the cholestatic liver diseases like primary sclerosing cholangitis or PBC. Or these patients could be having some pathogenic mutations in the bile acid transporters, as we discussed earlier. So on all patients where severe early onset family history, we'll have to be testing and following up. These patients, long-term follow-up, they seem to have a slightly increased risk of gallstones and the associated complications of gallstones like pancreatitis, cholangitis are also increasing with these patients. And there is a slightly increased risk of cancers of the liver and the biliary tree. And now it's known that these children who are born of mothers with ICP, they have an increased risk of adiposity and dyslipidemia.
Oh. So can ICP recur in future pregnancies? That will be the pertinent question that the patient will ask, right? Because today also she visited, her pruritus she says not come down that much. So she'll be worried whether this is going to recur in the subsequent pregnancy.
ICP has been known to recur in subsequent pregnancies, around 45 to 70% according to literature. The severity may vary from one pregnancy to next. So it's going to, the recurrence really depends on whether this particular patient is going to have a mutation or not. Okay. So it will be reoccurring in the 20% who got a problem or a mutation.
We already had this kind of a flow chart at the beginning. To sum up, can you sum up the entire dialogue for us?
So to again summarize, we have seen there are 3 groups of patients. One in which they're totally normal. You're going to periodically monitor. Group B, where the main cause for ALT elevation is some cause of hepatic impairment. We'll have to rule out the other pregnancy associated disorders. In group C, again, after excluding the main causes, you're going to consider. Now, the most important thing is the current change in the management is, like generally we are stopping UDCA at the time of delivery. Sorry for the busy slide, I couldn't modify it. So if someone is going to have a bile acid of less than 100, then you can stop UDCA at the time of delivery. However, if the UDCA, if the bile acids is more than 100, it's recommended currently to reduce the UDCA gradually 2 to 4 weeks post-delivery, especially if there are ongoing symptoms. So I think this is a current change in the guidelines.
I'm really happy to have you as part of my the dialogue of this webinar, and I thank Dr. Rajeshri and the entire OXI team for giving us this opportunity to voice out our concerns with a common problem which we meet in our practice, that is pruritus in pregnancy. For most of the time, except for you to say, we don't have any other armamentarium to offer the patient. And for the timing, it is as per your whatever recommendation, that's the only drug seems to be remaining with us. And thanks, Rajeshri. We'll bring this dialogue to a close, and thanks, Shanti Madam, for contributing so much to the literature which I have gathered from her. So
thank you. Thank you so much, ma'am. Thank you so much, Dana ma'am and Shanti ma'am.
And thank you for calling me, and Dr. Rajshri for coordinating. Thank you very much for the invitation.
Thank you, ma'am.
Thank you, ma'am.
Thank you.
Thank you, ma'am. Thank you, Dana ma'am and Shanti ma'am. It was a wonderful dialogue. As a mother who went through intra-obstetric cholestasis, I know how difficult it is to go through having pruritus and bile acids every 2 weeks. It's a nightmare. So thank you so much for simplifying to us. And it wouldn't have been much more better than what you did. Thank you so much, both of you. Ma'am, we are moving on every time with a...
Jairani ma'am, yes ma'am, welcome ma'am.
Sorry, I missed the first half, but I have a common doubt. So do we repeat the bile acids every time, every 2 weekly, or you give importance to the LFT, which is more significant in the condition of this women in the pregnancy, ma'am? How frequently will you repeat the LFT? Because there are some patients where the bile acid is increased as well as the LFT is also increased. So if so, which one you will give importance for the decision of the progression, or how frequent will you repeat it?
So, I mean, as I was mentioning, actually, the transaminases actually do not determine the prognosis of the patient. So, determine the prognosis, we are looking only at the bile acids. Though, what they say is that they're working out on a composite score of the transaminases and the bilirubin and the bile acids together. But bile acids is part of the score. So, though we are worried that the transaminases are going up, it actually is not determining the prognosis, because the main problem is only the fetal adverse outcome of the fetus. So it is primarily dependent only on the bile acids. It depends on how many fold the elevation is. So as long as the elevation is less than 3-fold, then we can repeat the liver function test even every 2 weekly. That would be quite enough. The PT-INR also, if it's normal, we repeat it 2 weekly. But the bile acids, again, depends on what is the degree of elevation for us to. So liver function test, if it's very marginal, 2 weekly is quite adequate, ma'am.
Thank you.
Thank you very much. Thank you.
Thank you, ma'am. Thank
Thank
you,
you.
ma'am. At the always, CME or a conference, we'll always wait for one panel discussion. And that interesting panel will always be in the last, because all of us will be waiting for that panel. It's one such panel discussion which we have today. Jaundice in pregnancy is not an easy topic to discuss. To pull through such excellent, eminent personalities from their field, a doctor, specialist from there, where we have the none other than Dr. Rekha Kurian ma'am to head the panel. She is director and consultant at Joseph Hospital, Chennai. Everyone knows more about her than me, than honorary secretary or consultant at Southern Railway Hospitals. She's a past president of Oxy. She's been the vice president of Foxy, managing committee member, vice chairperson at Tamil Nadu chapter for IACAG. She has special interest in endoscopy and infertility. We can't have a better person than you to run this panel, ma'am. Welcome to Save Motherhood Oxy Committee's gastroenterology panel discussion. So I would also take the opportunity to introduce the other panelist, Dr. Bharat, who has already given us a wonderful talk on constipation pregnancy as a senior gastroenterologist from Apollo Hospitals, Chennai. We have Dr. Madhumita Ramabhadran, infectious diseases specialist, who has been a senior consultant of infection control at MGM Healthcare, Chennai, who's also been consultant at Capstone Multispecialty. She's been an organizing secretary in Apollo Infectious Disease Conferences, a course director of Infectious Disease Update. She has multiple medals and awards to her credit. Thank you so much for joining with us, Dr. Madhumita ma'am. So it's my pleasure once again to invite Shanti Gunasingh ma'am, the senior consultant obstetrician and gynecologist who always supports young doctors, postgraduates and students. She is a past president of Oxy, former director and superintendent at IOG, and former HOD of KMC, and also served as a project director of Center of Excellence in Tubal Microsurgery for 6 years. And she's also been a past president of Women Doctors Association. Hearty welcome to you, ma'am, to join the panel. And last but not the least, we have Dr. Shobna Mahadevan, ma'am, who's also very close to me. We've known each other for quite some time now. She's a consultant, senior consultant at Sitapati Clinic and Hospital, Chennai. She graduated from MMC and masters from Stanley. And she's been an executive committee member of Chennai Menopause Society and also a member of RCOG. And she's very keen on teaching postgraduates for her MRCOG exams. So I think you have wonderful panel, Rekha ma'am, lined up. And over to you for the most interesting panel discussion on jaundice in pregnancy. You can unmute, ma'am.
Rekha ma'am, you're muted. Yes, ma'am. Welcome.
Good evening, everybody. It's quite late in the evening. One moment. Has the screen been shared? No, I don't think so, right?
Yeah, ma'am, you're sharing it.
To put it into play mode. Yep. Yeah. So I welcome the panelists, Dr. Bharat, Dr. Madhumita, Dr. Shobna Mahadevan, and Dr. Shanti. The topic today that we have to discuss, as we've heard so far, is jaundice in pregnancy. A lot has been said about it already. So let's move into that. So expert panelists, Bharat Kumar, Madhumita, Dr. Shanti Guna Singh, and Dr. Shobna Mahadevan. All Shobna and Shanti are expert gynecologists, and I'm very close friends of mine. So we'll just jump into the case because we are last and we don't have much time to waste. So this is a 29-year-old lady who's been treated for primary infertility elsewhere. And she comes with a pregnancy positive report to you with an early 7-week scan report with FH positive. Everything seems to be hunky-dory. So how will you proceed with this patient? Shobna, are you there?
Yeah, I'm there.
Okay, I can't see.
So I guess you're asking about the booking blood tests.
Yeah.
So we routinely screen apart from thyroid and complete blood count. And the topic of interest today being, I think you want to know whether we screen routinely for hepatitis B surface antigen and HCV antibodies. So routinely, it is our routine practice to screen for HBsAg. In our practice, we don't routinely screen for hepatitis C antibodies, though in high-risk groups who have received blood transfusion and all those people, we do screen them. So do you want to proceed further if it is positive and negative?
Yeah. And what else will you do? What are the other things you would like to do? 1 minute. Yeah. So HIV, VDRL, and HBsAg.
Yes. Yeah.
Hepatitis C you already mentioned.
Yeah.
So that is hepatitis C antibody. What about you, Dr. Shanti? Dr. Shanti Guna Singh?
Muted, Dr. Shanti.
Yeah. I will also be doing the routine blood test like CBC, blood sugar, then infection, HIV, VDRL, HBsAg, and hepatitis C.
Hepatitis C is also done routinely by you.
Yeah.
Okay, good. So she wants to screen. What about anti-HBs and anti-HBC? Would you routinely do these tests?
So sorry.
Yeah. Shobna?
So anti-HBs is usually a sign of immunity, isn't it? So we want to know whether somebody is positive for HBsAg, and if that is so, there is a risk of the mother. We have to test whether the mother has active liver disease, or the other important aspect is to protect the baby from perinatal mother-to-child transmission. So therefore, anti-HB as a sign of immunity is not routinely checked in a pregnant population. It is more in the healthcare professionals after vaccination to test for adequate immunity. Testing for hepatitis B core antigen antibodies, I don't routinely do.
Dr. Shanti, will you do any of these? Apart from the usual one, would you do these two? You are again muted, Dr. Shanti. Shanti, you're muted.
Only if she's HBsAg positive or anything, then we go in for other things. But otherwise, I routinely do an anti-HBs quantitative so that I know the immunity level also to a certain extent. Because I take it as an opportunity, especially suppose she is the immunity is less, that is less than 10, all that. And I give this hepatitis B vaccine even during pregnancy. So I do an anti-HBs quantitative also along with that to know her immunity. Core antigen, I don't do.
Okay. So that is an excellent answer because we are the primary physicians who need to protect her. Okay. So if she is not immune, then it is our duty to immunize her. And as you said, she would give it, will you give it in pregnancy or after the end of pregnancy?
No, I give it during pregnancy itself.
The first trimester?
Quite safe. No, usually what I do is, by the end of 12 weeks, I give them. Okay. So when we give the first dose of thing itself, it can be given.
Okay. So that's a great answer. I think we should all move towards that. Now, this lady, when you were giving her all these tests, she looked at the test and said, I have her old report which says I'm HbS-AG negative. I haven't brought it with me at the moment, but I know it is negative. What will you do? Will you cut off the HbS-AG in this panel of investigations that you're giving her? She says, I have a report because I've been treated for infertility. They checked me up. She doesn't have the report at the moment. Dr. Shanti?
Yeah, I think it would be wise to recheck always. She would have been negative earlier. Now she can still turn positive. So I think it would be wise to check her HbS-AG status now.
Shobna?
Yes. In general, I mean, even in pregnancy, we do it only once. We don't repeat it. But something is better than nothing. So if we don't have a recent report, and definitely if there is no report, we would always repeat it.
Saying I have done it, why you're making me waste money again? You're a money-making organization is what she would say.
So she can acquire this infection anytime, right? So she may have been negative before and she could have turned positive now. So at least in pregnancy, for the sake of the baby, we need to make sure that she is negative. That's how I would tell her.
So that's excellent. So whether, irrespective of whether she is HbS-AG negative earlier, remember she's gone through infertility treatment where she would have gone to the hospital so many times, needles so many times, and she could be. So I think we have to tell her this is for the sake of the baby. Once you say that, they are actually quite happy to do the test. What difference will it make if she says she's already vaccinated? She says, I don't want to do all this. If I'm already vaccinated, why do you want me to do this HbS-AG? Shobna?
So if she's vaccinated and we have concrete proof of that, then definitely she is not going to be HbS-AG positive. But like Dr. Shanti mentioned, we could test her adequacy of immunity by testing her antibodies and give a booster if necessary.
Dr. Shanti, anything to that?
No, I would also see sometimes they do not mount adequate response. So sometimes we have seen that. So I think I will again check, even if she says she is vaccinated, they'd have had 2 doses, 3rd dose. So many times this first year, when they enter medicine, they have, but then when we check, when they come to us as pregnant patients, these doctors, many of them don't seem to have immunity. So I think it is always wise to, safe to check rather for the baby's sake.
So I totally agree. And the WHO mentions this very specifically, whether she is vaccinated or not in pregnancy, or if she's done it recently as well in the past, we should examine everybody for hepatitis B, HbS-AG, and this is very important. So don't let us forget it. Okay. What does anti-HbS and anti-HbC indicated in this context of all this? What does anti-HbS and anti-HbC indicate? We've not, because we've done this 2 tests, as Dr. Shanti said. I think she explained it, so we won't dwell on that too much, because this is to look for whether she is immune or not, so that we can give a injection for her. So you said you will already vaccinate in pregnancy, and she said clearly.
Dr. Bharat wants to add on something.
Oh, sorry. Please, Dr. Bharat, I'm so happy.
Now,
yeah, please.
First of all, the role of HbS-AG. HbS-AG has to be definitely documented in all pregnancies, number 1. Number 2, the question about vaccination. If you look at certain people in certain areas are not aware, even though they turn out to be HbS-AG positive, there are lots of patients who come saying that they have been vaccinated.
Yeah.
So a person who's already been infected has also been vaccinated elsewhere as well. And they might claim that they have been vaccinated, but it is not going to give them any protection.
Okay.
So either whatever they claim to be vaccinated or not, we have to definitely document that HbS-AG is negative or not for each pregnancy. And coming to the role of anti-HbS and an anti-core antibody.
Yeah.
Anti-HbS is a marker of immune mounting by the patient. Whether the immune mount can be due to a natural infection or it can be due to vaccination.
Yeah.
If you want to differentiate between an anti-HBs and the core antibody, anti-HBs and the core antibody both are positive, then the person has acquired a natural immunity via a viral infection.
Yeah.
If you look at the infection of hepatitis B,
Yeah.
hepatitis B infection, if it is happening in a person who's in an adult who's presenting with jaundice, and if he has got an acute hepatitis B virus infection,
Yeah.
clearance is the rule. They will mount a good natural response against the virus. They'll clear the virus. In those patients, anti-HBs will also be positive and anti-core antibody will also be positive. That is the IgG anti-core antibody will also be positive. Both.
Thank you very much. Thank you very much. Can I just go on?
Yeah.
So this means that there has been a prior infection, and that as he correctly mentioned, there is sufficient immunity.
Correct.
Now, if HBsAg is negative and anti-HBc is negative, anti-HBs is positive, what does that mean?
You have given him the immunity, madam. You have given her the immunity in the form of a vaccination. So the patient has been vaccinated and has adequately mounted a good response.
Okay, that's great.
That's
so it is vaccinated. And if HBsAg is negative, anti-HBc is positive, and anti-HBs is negative. Dr. Madhumita, could you tell us what that means?
That just denotes a remote infections. Probably he had a HBsAg infection and he did not mount an antibody response.
Sorry.
Sorry, can you hear me?
It is a she here.
Okay, she did not, sorry. She did not mount an antibody response, or the antibody response has waned. The core antibody can denote a remote past infection.
So a prior infection and perhaps low immunity, right? So what action would you take for this?
Okay, ideally in a healthy population, we don't do anything. We just leave it. But if this population is going to be immunosuppressed, in those situations, we think of treating them. Otherwise, no treatment.
Now, would you vaccinate this person because anti-HBs is negative?
No, we wouldn't vaccinate this patient. Probably he will not mount a response.
Okay, fine. All right. So that is that. Anybody else has any opinion on that? Dr. Bharat?
Okay. If you look at the microscopic ways of how immune response happens, there are certain serotypes wherein it might not be mounted that well.
Yeah.
But if you have a person like this, it is definitely nothing wrong in giving a vaccination to those patients. And most of the times you can, this presentation is a very, very peculiar presentation, as rightly as mentioned by Dr. Madhumita. It's a remote infection, or we call it as an occult Hep B, in which case it is something which is lying inside the liver cell. But
we are justified in vaccinating this lady.
Yes, I would justify, but I'll make sure it is given in the deltoid. Most of the times it might have been given in the bums.
Okay.
You should make sure it is injected in the deltoid, and at times we can even increase the dose. A double dose can also be tried.
So I think, these are the things which I wanted to bring on. Okay, so now the results for this patient was that she is HBsAg positive now. Okay, what now? So we were talking of HBsAg negative and how to deal with that. Now we go on to this situation where there is HBsAg positive patient, Dr. Shanti.
Yeah, this patient is HBsAg positive. So I would like to know the activity, actually, viral activity. So for that, HPV DNA, all things have to be done. I would seek the help of a hepatologist and manager accordingly. Because if it is really high, HPV DNA is high, then probably she might even need antiviral treatment. So I would refer her, seek the help of a hepatologist.
Yes, definitely a multidisciplinary team would have to be involved, because there are so many possible combinations that can result. But as gynecologists, obstetricians, they would routinely do HBeAg as a sign of infectivity. It is said that HPV DNA is much more reliable as a sign of infection. So we have moved on to doing that. But as far as the viral load is concerned, whether she needs treatment, antiviral therapy or not, we would definitely seek the help of the hepatologist. Definitely, we will make a mark, make a note in the card and inform her about perinatal, neonatal immunization. And more importantly, screen the partner and see if he's still negative, vaccinate him.
Will you do anything for the maternal status? What is her status as far as this goes? Or do you want to do any test?
So all the other serological markers, as well as the liver function tests, we would do.
Okay. So liver function test, you want to do only aminotransferase, or you will do all the complete LFT?
So we are.
This is how we deal. I mean, when we deal with it, before they go, we do off these tests and then send to the hepatologist, right? So that's why I'm asking. You do the full panel of LFT?
Yeah, we will do, because if we are looking at the we are looking to see if she has active liver disease, then we should be doing the full panel of liver function tests, I suppose.
How about RFT? Any reason to do an RFT? Because LFT and RFT come quite close to each other.
No, if she's only HbS positive and I'm not looking at any other, differential diagnosis, is clear-cut patient, I generally don't do. But
so,
I would like to know.
Shobna, you said HBE antigen or anti-HBE antibody. Is that done, Dr. Shanti? Any comments on this?
Pardon?
HBE, Dr. Shobna already said. Anti-HBE antibody is done?
No, I mean, that's what I said. Only this I will know. After that, I will refer to hepatologist and seek their help and do accordingly.
Okay, so now we've done the HBV DNA.
Yeah.
I suppose this I can ask Dr. Madhumita. So what about, can you tell us something more about HPV DNA PCR?
So like the other panelists said, you're right in doing all these tests. So there are 4 things that we would look into before deciding therapy for any HBsAg positive.
Yeah.
One is the viral load. So we ask for the viral load. Second is the E antigen, whether it is positive or negative. Third is the LFT. So basically we would do transaminases. All that you required is the transaminases. Fourth is a fibroscan or the liver scan. So we see the grading of the fibrosis. So in patients,
can you tell me the cost of this fibroscan and where it's available?
Pretty expensive, where there are very few centers who do, and especially in centers where there are liver transplant which are being done, they only do it. So the radiologist does, and that's somewhere cost near about 18,000 per scan, if I'm not wrong.
It's got to afford that much. Do you really want to do it, or you want to do something?
No, in the initial stage, we don't do it when it's the first time that we are seeing. But ideally, these are the 4 things that we would look before starting therapy. But if we have just the 2 things, the viral load as well as the E antigen, whether it is positive or negative. Now, as you have already put on this, there are 2 ways that the copies are actually, reported. There are some labs which report as IU per ml, some lab which report as copies per ml.
Anything is Chennai, anything is more popular, or this is more abroad, which is a more popular one here, or just
No. I think both are used in Chennai. There are labs which report as IU per ml. There are labs which report as copies per ml also. When they report as copies per ml, then they will give you a tabular form below. How many copies and what is the significance? Whether, they will interpret it for you, whether detected above 10 or it is less than 10, 10 to 200. So they would give you the tabular form.
Okay.
So depending on that, we decide whether to treat, whether the patient is HBeAg negative or positive, and the viral load levels.
Dr. Bharat, can you tell us what is this, these values? Because we don't understand much about these. Could you help us with this?
Okay. See, all the labs, all the PCR studies nowadays give both IU and copies.
Okay. Before we go into that, can you tell me the cost of these tests?
It roughly costs around, if you refer to a hepatologist, they'll have lots of tie-ups. It will cost you somewhere around 1,500 to 2,000 rupees if they go through the hepatologist. Or if you're going to do it on the lab, they might charge you, if it is an Apollo hospital, then they might charge you somewhere between 8,000 rupees, 5,000 to 8,000 rupees.
Otherwise, 2,000.
If you go through a gastroenterologist or a hepatologist, they might have a tie-up with lots of companies. There are lots of health groups wherein they will give you the concession. You can
So the answer is there for all the gynecologists. Go through a hepatologist or gastroenterologist.
So it's either way beneficial for both. That's how it works. Now let's come down to this thing. Okay, role of E antigen and anti-HBe antibody. E antigen might give us a clue about one thing, whether it is a new virus or an old virus. Okay, if the E antigen is positive, the virus is quite new in the system.
Okay.
And this E antigen became unpopular over a period of time because there used to be a lot of pre-core. It is produced from a pre-core area of the virus, the genetic material. But it underwent a lot of mutation as the virus stays inside the system for a longer time. So over a period of time, E antigen became negative, but the virus might be actively dividing and it will keep on replicating more and more. That is the whole reason why E antigen became unpopular, went out of the system, and it is used for only this thing, whether it is a new virus or it's an aged virus. If the person has been having the virus in the system for a longer time, it might become negative, but still the virus might be actively replicating.
Fantastic.
So the endpoint of treatment became the viral load. That is the reason why HBV DNA became the first line for the endpoint of treatment. Because we cannot make this virus negative because it incorporates its genetic material into the liver cell. So it can get activated anytime. So the endpoint of treatment is an undetectable level of a viral load, which is your HBV DNA. No longer HBe antigen negativity was used as a result. So you look at the HBV DNA, if the viral load is more than 2,000, and if the ALT is elevated, you start the patient on treatment. That is the guidelines. Okay. And with regards to the routine use of fibroscan, we don't use routinely fibroscan for anyone who's coming for an initial HbA1c positivity. A good ultrasound is good enough. The guidelines even for surveillance.
Excuse me, what will the ultrasound show us in
ultrasound? You look at a few things because, as I said to you, the virus keeps living there, and the virus does not kill the liver cell. It is our immune system which kills the liver cell because it cannot clear the virus alone. So over a period of time, they can be fighting in between, on and off. So you can have certain changes of chronic liver disease changes if the person is coming to you, even if he's coming to you for the first time, or if she's coming to you for the first time with surface antigen positivity. So the routine test which we do, or which I advise, is we definitely need to do a complete blood count to know about the platelet count and the hemoglobin. Whether if the patient has been having some chronic liver disease, the platelet count might be low. Second, we have to do a urea creatinine and a kidney function test because if you are contemplating treatment, you might have to know, you need to know about the renal functions as well. A complete panel of liver function tests will also give us a clue whether the patient has been having some chronic liver disease, not just the transaminase alone. Because if you have an AAG reversal, albumin used to globulin reversal will tell us a clue that the person might be having the virus for a longer time or some amount of chronic liver disease could be there. And an ultrasound of the abdomen. An ultrasound of the abdomen needs to be done to know about any structural changes in the liver, whether there is a significant nodularity or is there a spleen which is enlarged. Those are the portal vein is dilated. Those are the clues we definitely can get to know from a simple ultrasound. So initially, a person is coming to with positive HbA1c, always do a viral load, full panel liver function test, E antigen plus or minus, make sure a kidney function test and an ultrasound is done.
Okay, thank you very much. So how do we monitor? So we said already this hepatologist for early initiation of treatment. Now you will decide on whether this patient requires treatment. And you probably will start it. How do we need to do repeat the DNA again?
Okay, every trimester, you will repeat. You are not going to start the patient on a treatment in the first trimester. Definitely no. And if you look at the natural history of hepatitis B virus, there can be one condition wherein the immune system can be quiet, but the virus can be actively replicating. The viral load can be very, very high in those patients. And pregnancy, which is commonly in young people, viral load can be very high if they are in an immune tolerance phase. Generally, we do not treat an immune tolerance phase. This pregnancy is the only exception wherein we treat an immune tolerance phase which will typically present with a
Excuse me.
very high viral load.
What is immune tolerant phase?
Okay. As I said earlier, this virus is a virus which goes and lives inside the liver cell.
Okay.
It considers the hepatocyte as a house. It does not destroy the liver cell. But our immune system is like the house owner. He can keep quiet and he will let the virus keep on replicating. And that is the phase wherein the virus will be actively replicating, keeping on infecting the nearby cells, but the immune system will be quiet. And this virus does not kill the liver cell because it's a house in which it is living. But the immune system one fine day gets activated and it wants to clear the virus. But at the time when it sends all the immune cells to clear the virus has actually become a part of the liver cell. So our immunity cannot determine or kill the virus alone. It kills the entire liver cell, resulting in liver damage. So if the immune system is keeping quiet and if the virus is actively replicating, then that is the phase we call as an immune tolerant phase. So we do not treat all the patients, whoever is having a very high load. With the normal liver function test, we wait. If the patient is young, in an immune tolerance phase, we do not treat. But in pregnancy, as the risk of vertical transmission is very high, if the viral load is high. So during the third trimester, we start the patients on treatment to actually reduce the viral load.
So only in the third trimester? You won't start earlier?
No, we will not.
Are there not drugs which are safe in pregnancy for these very high viral loads? I'm just asking.
Yeah, we generally don't. They are not the safest of the safe during the first or the second trimester. Definitely not in the first trimester. During the end of the second trimester or in the 7th month, we might initiate if the viral load is very high.
Okay.
And this is the only condition in hepatitis B where we stop the treatment after 6 months after delivery. Nowhere else, once we initiate hepatitis B treatment, we do not stop the medicines. It is considered for life. Whereas in only immune tolerance, pregnant women, very high load, just to prevent the vertical transmission, we start them on the third trimester, continue for 6 months post-delivery and stop.
Okay, Dr. Madhumita, do we need to repeat this HBV DNA again? Because probably when we sent to you, it was low. Is there a chance that it could go higher, and do we need to repeat it anytime?
Definitely, like Sir said, at least once in every trimester, you need to repeat it because there are possibilities that they can actively replicate and your viral load can increase.
And you will not start in the second trimester. So why repeat in the second trimester? You will not start treatment.
Just to know whether she is increasing or not. Some patients may not increase. See, again, choosing to treat generally will depend upon the viral load. Like Sir said, at third trimester also, if her viral load is less than the detectable LDL, what we call less than lower limit of detection, we would not treat. So I would definitely do
the reason I'm asking in second trimester is you are not going to start treatment. So there's no purpose in doing a test, which is quite expensive. How expensive is this HPV DNA?
He already said if you go through a hepatologist, he'll get it done through 1,000 rupees. So,
with him, we can do it in the second trimester, but otherwise, I don't think we can do in the second trimester. It's quite an expensive test because you're not going to take action on it. What do you feel, Dr. Bharat?
Madam, it will preempt the patient and it will preempt the treating doctor as well. So it will give you a good clue that it shouldn't be missed in the third trimester.
Third trimester, we will definitely do it.
Yeah, that is correct. And the second one, if you are going to do any intrauterine interventions, for example, an amniocentesis, or if you're planning to do some sort of a biopsy intrauterine, because intrauterine transmission of virus does not happen. But if you do some sort of an intervention or tests, so you do some tests intrauterine, then the risk of transmission is high. And if you still have a high viral load, you become very wary about trying to do any interventions like that. So the one condition wherein you can have an intrauterine transfer is that if you have some sort of a biopsy or some sort of a testing for...
How about LFT? Does it have to be repeated?
LFT, for various reasons, you do during your pregnancy. And doing a viral load, and we always have, it goes like a battery of tests. We always do an LFT and a viral load. But if you ask me what goes up first, it is a viral load which goes up first. The destruction of the liver cells happens secondarily, and the elevation in the ALT enzymes, there's a lag. So the first to go up will always be a viral load. if you see an increasing viral load, you obviously will do a liver function test as well.
So right now, we've had a maternal antiviral therapy if the DNA is up to a certain level. So basically in this, what we have done is we have gone for maternal status to see what is our liver status, and then if looking at the antibodies, looking at the DNA, so that is where we reduce the risk of transmission. So these were the two purposes of the whole thing. First of all, find the maternal status of her liver condition, and second, we need to look at liver transmission. Anything else is there for this patient? Dr. Shanti, Dr. Shobna, one of you can answer. Anything else for this patient?
No. Of course, we will be looking at infective markers otherwise also. And
Okay.
especially when she's this HBsAg positive, we have to do the other ones.
What about her family? Will you look at anything?
And what about, sir, they talk about Delta, looking for D. Should it be done?
No, madam, it's not routinely done. If HBsAg is, if you keep the viral load of hepatitis B quite well, you indirectly treat your Delta as well. So if you concentrate, Delta doesn't happen without hepatitis B. So
Okay.
you concentrate primarily on the hepatitis B, things should be well under control.
Dr. Shobna, anything else you want for this patient? You want to discuss anything with her? Say she's, her husband, would you test him and see?
That we have already seen because
We have not seen. Unless you say it, it's not been done.
no, husband status, if she HBsAg positive, immediately we look at husband status and then vaccinate him. That is most important. We also keep on reiterating about the importance of giving hepatitis B vaccine.
Will you test the other children? Suppose she's had one or two previous kids. Should they be tested? These are all things which we face day to day in life. That's why I'm asking.
It's also very, very important. Because since she's HBsAg positive now, maybe she was earlier.
She was positive.
So it's very important to test the previous siblings also. That is previous children.
Now, Dr. Madhumita, can you tell us a little more about the drugs for the therapy? We don't want too much because we don't understand too much about that. But
Okay, there are two drugs which can be safely given. One is a tenofovir or an emtricitabine based therapy. And like Sir said, pregnancy is the only condition where actually we give it post-op, continued 3 to 6 months post delivery. Recommendation is just 3 months, and she can continue to breastfeed also. And for the child,
side effects for the drug?
Side effects, not many. TDA.
You mentioned that we have to do the renal function test.
In tenofovir, So tenofovir, you need to keep checking your creatinine. So that's the only side effect of tenofovir-based therapy. Whereas,
I want to know the cost of these drugs. Is this a drug which is cheaper? What can be used for a poorer patient?
I think both are cheap. You get them cheap. 30 tablets would cost 300 to 400 rupees.
Okay.
So,
and what is the endpoint of this treatment? Where you, as I think he already mentioned, you just go on till 3 months after. You don't look at any of the other values at any point. You don't look at DNA, whether it's coming down. Nothing. Am I right?
Yes.
Okay, fine. So, Dr. Shobna, what are the risks to the fetus once this lady is diagnosed with HBsAg positive? All these other things our hepatologists are looking after. What are the risks to the fetus?
So the main risk to the fetus is the transmission of the virus, which happens, obstetric risks you're talking about. If she's just a chronic carrier, her seropositivity and all the other markers are negative, usually there is no obstetric complication. Of course, there are risks in the way we manage labor for the healthcare professionals. For the neonate, definitely there is a increased risk of transmission of the virus. But
some of these have been said that prematurity, low birth weight, and some antepartum hemorrhages can occur in these patients. probably because of coagulation. I do not know why.
Probably, but
In practice, we don't see this often. We don't see this at all if she's just seropositive, right?
Now, if the woman has cirrhosis, then of course we all know it's very poor maternal and fetal outcome. And now this patient, because we've said it's low birth weight, prematurity can happen. Do we do a lot of serial scans for her for growth, Dopplers, anything like that?
Well,
if she's being treated, I'm saying if she's being treated, that means the viral load is high. It's not just.
Definitely, if she's having liver disease and she's under treatment, it would impact the growth of the fetus, and we would definitely do serial growth scans every 4 weeks, starting from 28 weeks onwards.
And how about the neonatal care?
So, I like the picture. So, within the first 24 hours, the neonate should be given hepatitis B immunoglobulin as well as the first dose of the vaccine. And breastfeeding is not contraindicated. It should be encouraged. And there is no, I mean, are you talking about a
cesarean delivery helper? At one point, you say it will help prevent transmission to your newborn. What is the Dr. Shanti, you have anything to say on that?
No, there is.
Here, when we are going to give vaccination, hepatitis B vaccine and immunoglobulin within the first 12 hours, I think vaginal
that is more important. Okay.
But then universal precautions should be strictly adhered to. That is the most important.
Yeah.
The whole, so that is important. But
yeah.
I think a cesarean delivery helps only for obstetric indications.
Okay, fine. So that is that. So now we will go on. That was hepatitis B. Now we will go on to a primee who is at 6 weeks. She's come. She's negative blood group. Husband is Rh positive. She received anti-D at 28 weeks. At 33 weeks, she presents with itching all over the abdomen, upper and lower limbs. What would you do now for her?
Yeah.
Dr. Shanti?
So we will, she has developed itching, generalized itching.
Yeah.
And we have to see for any rashes if they are accompanied only by excoriations or whether there are any other rashes.
Fantastic.
And suppose if there are no rashes, only excoriation, we have to think about IHCP. So that event, probably we will be doing an LFT and serum bile acids.
Okay.
That is very, very important.
So when you say LFT, it doesn't include bile acids. So you're extra, you're doing also.
To be mentioned separately.
Okay.
That is very, very important. And so bile acids 10.
Okay.
So 10 means they say it is just normal, high normal. But then as per RCOG, up to 18 is okay. But then I would probably repeat it every week.
Okay.
So that I would know the trend. That is also important. In the meantime, probably I will put her on some emollients and antipruritics to alleviate her itching and probably UDCA too.
Okay, so you'll start her on UDCA. Dr. Shobna?
Yeah, I think I would agree with her. And particularly a symptom of itching in the palms and soles is typical of IHP, ICP. And so
adding any betnisol, steroid, anything, will it help her, do you think? Have you tried any time?
The steroids are indicated not per se for the treatment of this problem, but in refractory itching.
Okay.
If the UDCA and the local emollients are not helpful, a short course of steroids, they do give very good relief.
Okay.
But of course, it's not done as a routine, and in the presence of an associated GDM and all of that, we need to keep that in mind. But yes, it may have a small role, like steroids.
So she is then a week later, she's admitted with absent movements, but she was managed conservatively. CTG was okay, scan was done, all okay, and then she was discharged. and her hemoglobin was found to be low. She was given iron injection. A week later or 2 weeks later, she presents with fever and chills, which is managed conservatively as urinary tract infection. I mean, this is what one thing we will think of commonly. And then she was admitted. 3 days later, we send her off with this urinary tract infection treatment, and she comes back with fever persisting for 4 days, 2 episodes of vomiting, and she has history of travel.
Now, what are bile acids, LFT?
Okay. So, yeah, investigations. So now she's at 36 weeks, and we did her LFT. Can you see? I think is it hidden? Yeah. Okay. So bilirubin is 2.7. Yeah. AST is 19, ALT is 17. So only bilirubin is elevated. Alkaline phosphatase is elevated as well. And bile acids have now become 15. So she's 36 weeks. What would you do now? Oh, sorry. So what would you do now?
I would get see her serum bilirubin is raised now, although her AST is quite normal.
Pardon?
So it's quite rare for bilirubin to go up to 2.7. It can happen, but I would definitely like to rule out in the presence of vomiting and travel, any other coexisting problem, particularly a viral hepatitis also I would like to rule out, because in pure and simple ICP, and the level is not that much, like 10 and 15, right?
Yeah,
so
10 has become 15. So Dr. Madhumita, anything you would like to say about this? Dr. Madhumita, are you there?
Yeah, sorry. With an acute febrile illness and I would call this as an undifferentiated fever. So I would also look for certain tropical illnesses which can present this way. Your AST, ALT may not be elevated. I would look for malaria. I should look for scrub typhus, which can present in an atypical manner.
All right. All right, so we did that. Now we have to do something about her. She's 36 weeks. Would you want to make her continue till 38 weeks? What is your plan, Dr. Shanti or Dr. Shobna? Obstetric wise.
So, see, if she's feeling the movements well, CTG is normal. In the presence of an acute infection, acute condition, we can delay the induction, though ideally we should be inducing at the completion of 37 to 38 weeks. With the bile acids not going up too high, 10 and 15, we can wait up to 38 weeks if she feels the movements well and if monitoring is okay.
Yeah, no, see, when there is slightly elevated serum bilirubin, I would, and in bile acids are not that high, I think I will wait till the acute phase is over and then probably induce her. Find
Okay. We'll work her up and make sure we are not missing any other like tropical infection. And
so
then...
now you okay. Now you reached that week and you're going to deliver her. Any investigation you would like for her?
So because there is the coagulation profile, I would do along with the other liver function tests, because that can have an impact on the delivery and her risk of bleeding. So in anybody with ICP, particularly close to the delivery time, you would do a coagulation profile.
The coagulation profile, fibrinogen was elevated. I can't explain it why, but that was shown in this. Okay, so she had no excessive bleeding. However, her coagulation profile was normal and she was quite okay. And after delivery, all values returned to normal within a couple of days. That is what I think we would have expected. Now, this is another case. I'll go through with it fast. 22 years primey, first visit at 28 weeks, itching all over again at 35 weeks, again started on UDCA, and she had reduced movements and pruritus, again severe pruritus. Bilirubin was mildly elevated. Bile acids were elevated. I mean, bile AST and ALT was elevated, and alkaline phosphatase was 243. Shobna, what would you like to do?
So she has reduced movements at 36 weeks.
Yeah.
So this could be intrahepatic cholestasis with an elevated bile acid. If she has, sorry,
bile acid is 10.
AST
is what that's a borderline, is the upper limit of normal.
Yeah. Bile acids is 10. AST and ALT are elevated.
So
what do you want to do with her obstetrically?
So if the 10 is just upper limit of normal and transaminases are elevated, of course, the other one to look out for the other conditions in pregnancy, like, preeclampsia with some end organ abnormality, and all those things we will rule out, and definitely plan her delivery with after ruling out a coagulopathy.
So she was delivered, ARM showed a thin MSL, she was delivered normally, all values normalized in 2 days. So my question is, this diagnosis we all said is intrahepatic cholestasis of pregnancy. Then why was the bile acids not elevated? Any opinion on that, Dr. Bharat or Dr. Madhumita?
Madam, the time when they take the bile acids also can vary. At times, one-off value might not be the right parameter. Okay. When it comes to intrahepatic cholestasis of pregnancy, you look at two things. One, the mother, and two, the baby.
Yeah.
When it comes to the mother, the outcome is usually very good. The patient does quite well.
Okay.
Whereas when it comes to the baby, the chance of stress and preterm and all is quite high. So that's the reason why, as rightly mentioned in the previous lecture, there's no predictable pattern for a preterm or a stillbirth. So they will have a definitive point of early delivery.
Okay.
But when it comes to a liver function test approach in a person who's pregnant, there are certain parameters which are normal, certain parameters which are definitely need to be investigated. Okay. One thing which has a leverage for normalcy is your alkaline phosphatase, because the placental alkaline phosphatase in the baby's bone also produces alkaline phosphatase that can be normally elevated in a pregnancy. So if you approach a liver function test abnormality in pregnancy, ALT, AST, if it is elevated, definitely it warrants investigation. So just not by the bile acids alone, you cannot presume it has an intrahepatic cholestasis. In this case, if the patient is presenting the fever and if there's an elevation in the enzymes and definitive causes for the fever needs to be evaluated, as Dr. Madhumita mentioned, you'll have to work up for tropical fever and other conditions wherein you can have an indirect hyperbilirubinemia, you can have an elevation in your ALT and AST, and patient will have some amount of causes for the fibrosis.
What I wanted to ask was, is it because of the UDCA that was used? Because many times we started empirically.
Definitely it helps, madam. UDCA definitely helps in reducing the bile acids.
So then our results will not show bile acid. That's what I just wanted to come around. So
it can.
That may be the reason why these bile acids were not elevated. So it gives us a false information, and then we are thinking of other reasons.
But this fever also needs to be addressed, no, that's what I wanted to stress. This fever always needs
to you have to investigate, but I think it was a UTI at that point.
Right, okay.
Anyway, so these are the risks which you would like to, meconium stained amniotic fluid is quite common. Spontaneous preterm or iatrogenic preterm can occur, and ICU admissions can occur. And stillbirths increases with the values more than 100. I think it was talked in the previous lecture, so we won't go too much into that. So,
can I ask a question to hepatologists? Yeah. How do you rule out AFLP in such cases?
Madam, if you look at a mother and a pregnant mother, you look at general constitutional symptoms. If you look at the other problems, if the patient is very drowsy, patient is having hypoglycemia, patient is quite dehydrated, jaundice is worsening, significant coagulopathy. If you have other systemic problems, you always worry about a major problem which can be a detrimental parameter for both the mother and the baby. If the patient is otherwise stable, not much of a systemic symptoms, we think about issues like IHCP. But if the patient is sick, if she's having other systemic problems, then you should always have a very high index of suspicion for AFLP. and eclampsia and preeclampsia and HELLP syndromes. So those are the serious problems which can affect pregnancy, which are intrinsic to pregnancy, wherein early identification and early termination of the pregnancy is the only way out. If you are thinking about an AFLP, delay in terminating the pregnancy can result in a fulminant hepatic failure for the mother, and they can have a very worse results. So systemically, if the patient is very unwell, not doing good, then you have a very high index suspicion. And when it comes to the hepatologist, the mother takes the priority. So early termination of pregnancy will be advised straight away.
Okay. So as this picture shows you here, sometimes the scenario can be quite confusing. These are all nuns with short skirts, but they're actually sitting on bar stools which have those legs. So sometimes we get pictures like bile acids low, but it is intrahepatic cholestasis probably because of the UDCA. So as we said, increasing gestational age is a risk in all these women. So if it's more than 100, of course, all of you all are going to terminate, but increasing gestational age also can be complicating. So that is why many of us will terminate before 38, 39 weeks. So what is your, suppose your value is above 100, of course you will terminate. And at what weeks will you terminate? If it is above 100.
Above 100, it needs to be terminated. That is what I would say. Still, I would steroid her and then deliver.
Okay, fine. And if it's below 100, above 40, but below 100, when will you terminate? Because different schools, like for example, RCOG and ACOG have little different guidelines. So that's what I just wanted you to bring out, that there are different and what do you follow? Dr. Shobna, RCOG?
So 37 weeks, we would induce and deliver if you have above 40. But if it's more than 100, definitely earlier 36-week induction and delivery is what I would.
Yeah, the RCOG is little more early.
Earlier.
36 weeks itself, even above 40.
Yeah. And fetal growth restriction, generally, yes, if it's an early onset and severe ICP, there can be a risk of, but recent guidelines even say that there is generally no risk of
generally
growth
no
restriction.
risk of FGR and oligohydramnios in these patients. Okay, I'm trying to. Yeah. So I think, what is the dose of this ursodeoxycholic acid, UDCA? What is the dosage, Shobna, or what
we start usually with 300 3 times a day, but it can go up to 600 3 times, 1.8 to 2 grams. Up to that dose we can give.
For how long will you give?
So,
Auntie, you want to say?
10 to 15 milligram per kg per day.
Max. It's 15 milligram per kg. You can go up to 21 milligram per kg. How long will you continue this?
Yeah, till
delivery?
Yeah, till delivery, I think I will.
Okay. Do you think that's okay, Dr. Madhumita? Dr. Madhumita, I think you're...
Okay, I'm not a hepatologist, so I don't know much about it. Yeah, I think if the bile acids on repeated
Madam, weekly once till delivery, bile acids and the liver function test.
Okay, fine.
We always keep checking the liver function test along with the PT-INR and bile acid, and along with the fetal monitor.
Any side effects of this drug?
Very well tolerated drug, madam. Usually very well tolerated. You might have a little bit of loose stools at the most, but usually a very safe drug, because this is one of the bile acids which is produced by our body. So it's one of the most water-soluble bile acids. So that's why it improves the bile flow and stabilizes the membrane.
Have you used any of these other drugs in pregnant women?
Acerinosin, methionine, cholestyramine, rifampicin. Rifampicin is useful for pruritus, but cholestyramine is used for if the bile acids is very much excreted through the intestines, wherein this bile acid binders will be helpful. Person presenting with diarrhea, likewise. Not much of a use with pruritus. Acerinosin, methionine, we generally don't use in pregnancy.
In pregnancy, okay. So monitoring this pregnancy, any protocol as you said, bile acids will be repeated. I think you already mentioned that LFT also has to be done. Okay. So any other tests you need to do for her?
Me?
So delivery, we have decided. We have to warn her about recurrence in her future pregnancy. How about contraception for her?
Increases the risk of ICP, madam. ICP is one of the precipitating or risk factors for in subsequent pregnancies, OC pills and hormone tablet exposures.
So, Shobana, what will you give her as contraception? This woman needs contraception because she's petrified her recurrence with the next pregnancy. What contraception will you advise her?
So barrier and intrauterine contraception is definitely preferred. But progesterone only contraceptive, I think, is recommended. Safe.
Yeah, I'll get that as well. Okay. And do you think it will affect her HRT?
See, all estrogen containing, I mean, they will have the tendency for any estrogen containing pill.
Okay, fine.
But because this is a pregnancy specific condition and there's no long-term impact on the liver, I mean, there is no chronic liver disease risk. Okay. So when once she is older and if it is indicated, I think HRT is safe.
Okay. So I think we will go on. Just a quick case. This is a primee who has regular visits up to 6 weeks, admitted with high fever and burning micturition at 32 weeks, and put on antibiotics IV for that. And in her fever profile, NS1-AG is positive. What should we do? Dengue is positive. Dr. Shobana?
So she is 32 weeks.
32 weeks, yeah.
Okay, so dengue positivity, the main the treatment is supportive.
Yeah.
So because hydration is a very important aspect of the care, and dehydration can predispose to coagulopathy and thrombocytopenia. So we would definitely admit her if she has high-grade fever and monitor her temperature, give her oral fluids and IV fluids. And then generally platelets tend to start falling once the fever breaks.
Okay.
So she is 32 weeks, so there is no imminent risk of delivery. Of course, she can go in for preterm delivery. Any high fever, febrile illness can predispose to preterm labor. So platelets dropping to 28, generally we wait. We don't give transfusion till it drops to less than 20.
Madhumita, Dr. Madhumita? You're infection specialist.
Yes. So, as ma'am correctly said, the platelets generally drop when the fever differs. So when you do at least 12th hourly monitoring, if you're seeing a drop in platelets, and for a normal person, we wait till 10,000, till the platelets drop to 10,000 if there is no bleeding tendency. But in a pregnant woman, we don't have a clear guidelines, but I think the arbitrary amount level of 20 to 50,000 can be taken. And if there is a drop below 20, you should transfuse platelets.
Any other investigations we need in this patient?
The LFTs, because in dengue hepatitis is very common. So you need to check LFTs often. And many a times you can have dual infections also. So malaria is another mosquito borne. I would check for malaria also in this patient.
So a few days later in the hospital itself, she had severe abdominal pain, epigastric pain, dyspnea and hematuria. What would we do then?
An ultrasound abdomen and see if she's got hematuria, she needs platelet transfusion, definitely.
Okay.
This is probably severe dengue progressing into DHS or something like that.
Okay. So, yeah, so she is a little complicated and therefore, I mean, we decided we can't manage her in our hospital and we had to shift her out to an ICU. So, and there they found that her AST and ALT was elevated and fibrinogen was a little low. 183, would you consider low?
Yeah.
Okay.
Yeah.
Pregnancy.
Okay. So this was her findings. And she's still continuing pregnancy. slowly the platelets and the LFT improve. So these are the various places where we find that we have to deal with LFT. And as you said, sometimes we deal with dengue, but we don't really look at LFT. But in this patient, she whole thing precipitated and then LFT was done subsequently. But we had not monitored it. Okay, just for a differential diagnosis, this is a 22-week lady with generalized pruritus, not settling, and this was her hand. What would you think? Dr. Shanti?
She's having some lesion.
Yeah.
So I think that has to be evaluated.
Dr. Shobna?
I'm not able to see very clearly.
Eczema? Is it?
This is actually eczema, it would be. Anything else?
To me, it looks like scabies.
Scabies.
This is after 2 days of treatment. That's why it's looking dried up. But basically, I just wanted to bring this out because she clearly mentioned if there are lesions, then we don't call it intrahepatic cholestasis. Then it is some sort of a skin disorder. And the diagnosis will be PUP, ultricaudal flaps and papules. So this is what, so we diagnosed her like that.
Yeah, but you occur a bit later. There'll be umbilical sparing.
I didn't get you. Say again?
No, but here umbilicus is not spared, no?
Yeah. So this is the next picture that she came with. All over the body, it has spread this lesion. And then it progressed to bullous lesions. What do you think it is?
Pemphigus?
Yes. So this was, therefore, we had to have a multidisciplinary team with a dermatologist. Skin biopsy showed that it was
Pemphigoid.
Bullous pemphigoid antibody was positive, and she was started on prednisolone, no relief, azathioprine added, and then pruritus settled, and we delivered the baby early. So medicines were tapered. Complete recovery took nearly 6 months, and recurrence of symptoms may occur with OCPs. And this is another one condition which again OCPs can cause, and even during menstruation, some of them worsen. And if it is not diagnosed and treated, this can lead to preterm delivery and neonatal pemphigoid gestations. So I just thought I'd bring these skin things also because it was pruritus, just as a differential diagnosis. So to conclude, jaundice in pregnancy is not very common, but when it presents, we have to be prepared with answers and what are the questions and the investigations that we will do. When should we refer to the hepatologist? We should have our level at which we know that we have to refer now to hepatologist. And we have to have the obstetric management PACA in our hands for each of these conditions. And so let's hope for a good outcome for all our obstetric jaundice patients. Thank you very much. Thank you to all the panelists, and thank you to Oxy and Dr. Jayarani and Dr. Rajeshri, all of them for organizing this and giving us a chance to be here. Thank you very much.
Thanks to the experts, ID specialists and gastroenterologists.
Yeah, thank you very much.
Interesting cases.
Yeah, yes, ma'am.
Different cases.
It was a very engaging panel, ma'am. It was, and panelists were equally very good, and we had a very interactive session, and we learned a lot of new things from this panel. A lot of cases which we don't ordinarily see. And having the ID and the hepatologist really helped us in learning a lot of things that we will not come across every time. It was really very interesting, ma'am. Very interesting. Very engaging.
There is a question in the chat box. Drug to be avoided when the patient is on tenofovir, other than any nephrotoxic drug.
Can you answer, Dr. Bharat?
In general, are they asking for any other specific interactions, or it's like any other medicine, madam? It's used like an antiviral. There are no specific contraindications that you should not give like this and you should not give like that. So preferably hydrate quite well. That's the only important thing which we advise anyone who is taking tenofovir. Quite a bit of hydration, and preferably avoid any other medicine which is usually given, is not given during pregnancy. That's all how it works. No specific that you should not give this, not give like that. Not like that.
Is Caladryl lotion safe? Contains an antihistamine too, Dr. Shobna or Dr. Shanti?
Calamine lotion is quite safe and soothing, and we can add an antipruritic orally also.
Okay, like?
To bring down the...
Like what?
Levocetirizine can be added.
Okay, fine.
Really,
I think those will be the first line before we jump into UDCA, right?
Yeah.
We are still monitoring the bile acids.
Yeah.
Anything else anybody wants to bring up? Dr. Madhumita, would you like to bring up anything we gynecologists should know?
Nothing. I think ma'am did discuss hepatitis B. I don't see a lot of you giving the hepatitis B vaccine during pregnancy, or maybe in the preconceptual period also we should discuss about hepatitis B vaccination in pregnant population. I mean, in the ANC period or even before that.
We want your confirmation that it is safe for us to give them. Tomorrow we'll start giving.
It's 100% safe.
Okay. So it is quite safe in pregnancy.
Yes, it's a recombinant vaccine.
A recombinant vaccine. Very safe in pregnancy.
And the other one is an influenza vaccine, which I think, it's an influenza. In India, it's not like seasonal. We almost have it throughout the year. We have at different stages, because our monsoon period, especially in Chennai, we do not know. We always see a post-monsoon hike, but then it happens both the times. You have rain in June, right? Now, like the way you're having, you have rain in November also. So I think influenza vaccine is something that we should think about in our pregnant population. And the other thing, I think we're all now moving to the Tdap vaccination also in pregnant women, just for the cocooning effect. So that's something that routinely we should give in our pregnant population.
I think most of our members are doing both influenza vaccination and Tdap. Dr. Shanti, you wanted to say something?
Yeah, all of them. Those have become the routine now.
Okay. Right.
Just wanted to ask about Tdap now that you're mentioning. So generally tetanus alone we were giving, and that doesn't require a booster until 5 years have elapsed. So Tdap we are giving for the sake of neonatal protection also. So should that be repeated every pregnancy?
Yeah. So as per CDC, they say every pregnancy you are supposed to give a Tdap. Ideal recommendation for Tdap again is once in a lifetime, or for a person who has received the entire schedule of tetanus, diphtheria, pertussis vaccine in their childhood. TD is something that we give once in 10 years. So you don't have to, if somebody has received a TD, you can repeat it after 10 years. It doesn't matter he gets a scratch or he's undergoing an operation. Never mind. You can, still say that he's protected. For Tdap, they say it's one dose as an adult in the general population. But in pregnancy, every pregnancy, they say you need to give a Tdap. Even if the pregnancy happens, in 2 years' time, you give a Tdap. Yeah.
That is to give protection to the newborn, right?
Yeah, newborn.
Not only to the baby, but also to the mother, because we get diphtheria cases now, which we are not very much aware, So I think it is...
Mother is protected if she has received it before, right? That's what I understood.
Correct.
For the baby, I think...
For the sake of the baby, we have to repeat.
Yeah. So I think those are good lessons to learn from the disease person. Thank you very much for guiding us.
Thank you, ma'am.
So thank you, Rajeshri.
Thank you.
Thank you so much, ma'am. Thank you for such an engaging panel. It was very interesting. Plenty of us stayed back just to hear from you and all the panelists. Now would I request Dr. Rajeshri ma'am to deliver the vote of thanks, please.
Thank you. Thank you so much. It gives me real joy and pride to deliver the word of thanks. At the outset, I would like to thank Dr. Jayarani Madam, President Oxy, and Dr. Kundavi Secretary for making this webinar possible, giving us an opportunity to do the webinar. I extend my thanks to Dr. Asha, who was readily consented to be there as a chief guest, and also Dr. Kasturi Madam, both of whom were there to bless us and start off the webinar. I'm thankful to all the speakers, Dr. Nitya, Dr. Bharat, Dr. Dhanlakshmi, and Dr. Shanti ma'am, We really had an exhaustive session on all the topics, and it was really useful, very practical, and we had a lot of tips. And finally, a big thanks to Rekha ma'am for getting interesting cases in the panel, really engaging all the panelists, and we learned a lot out of this panel. A word of appreciation to Deepti, who was a master of ceremony, and I would like to thank the platform, Shield and Sahiti, who has been there for giving us this platform. And finally, I would like to thank the audience for the phenomenal response. And I hope to keep you engaged with much more activities throughout the year. Thank you all. Thank you. Thank you so much.